Okay. So today for UG, there are two kinds of presentation. One is TB diagnosis. Some 18 or 19 presentations are there. Already we shared the list to you. So each 5 students, one representative will come and present the topic. So that presenter get one certificate, presentation certificates. Others only get conference certificates. Okay. So award for diagnosis stream, one winner, one runner will be getting first place and second place. In diagnostic stream, 2 awards are there. Winner and then overall presentation, runner and the winner. So these are the flow of presentations today. Each presenter will be given 5 minutes of time, 4 minutes of presentation, 1 minute of discussion. So that means you have to present the whole thing. The presenter name, your group member's name, your title, then respective, the introduction, objective, text, conclusion. Okay, everything you should present as a flow. Afterwards, the reviewer might ask some questions. Then participants also will ask some questions. Okay. So that is the flow. Next we call upon next presenter. The flow is already there. The schedule is given. The next presentation should be ready and come front. You should not wait for calling your name because you know the second upcoming presenter. So you should come front. Shall we start? Any doubts?
Good morning to all around present here, respected faculty members, dedicated scholars, and distinguished attendees. We welcome you all to this event. It gives us immense pleasure and a profound sense of honor to extend a warm and hearty welcome to each and every one. So without getting any delay, let's get into the session.
First, we'll have a poster presentation by the MBBS students. The first the first topic will be TB diagnosis. And for this, I invite Dr. Gayatri, Department of Community Medicine, and Dr. Anush Anthony, Department of Respiratory Medicine, to be the reviewers. The first team will be Divya Darshani and team on the topic risk and vulnerable groups of TB.
Good morning to everyone present here. This is Divya Darshani, and my team includes 5 people, including me. The others are Devamashini, Dhanvashini, Danita Ishwari, and Devamitra. And I'm here to present a poster on the topic of risk and vulnerable groups of TB. First, let me have a quick recap on what is TB. TB is a disease caused by bacilli, which is called as Mycobacterium tuberculosis, and it affects lungs and other extrapulmonary organs. Okay, first we will start with what is risk groups. Risk groups are people who have high risk at infecting TB due to their biological or behavioral factors which compromise their immune function. Then who are all called as risk groups? Risk groups are people with HIV, diabetes, silicosis, and alcohol use disorder, tobacco usage, and injecting drugs, undernourished people. Then how people with HIV can contact tuberculosis? They have low CD4 count cells, so their immunity is impaired. And people with silicosis, they have impaired lung function, and there will be inflammation and scarring, which due to which there will be an increased macrophage and other phagocytic cells, which directly influence the replication of Mycobacterium tuberculosis. And people with diabetes, they have a compromised immune function, and their kidney function will also be reduced, due to which the clearance of their bacilli will be less. Undernourished people, they have a high prone chance of inflammation and other diseases also. People with alcohol use disorder, they have a delayed diagnosis and treatment, and they have a weakened immunity. People using tobacco, they will be having an impaired lung function, and their alveolar macrophages will also be increased. and people injecting drugs also, they will have a compromised immunity. Then there is another set of people who are called as vulnerable groups. Vulnerable groups are people who have high risk of contracting TB disease due to the place they work or the place they stay at. Example, healthcare workers, community workers, and sexual workers. Um, okay. And how sex workers can get TB due to it? They have they have high risk behaviors and they have multiple sexual partners and they also have a social stigma. How pansexual also comes under an vulnerable group. Pansexual, they also have under social stigma. Then hospital care workers, hospital community workers, they are also at the risk. They are also comes under the vulnerable group of TB because they have a repeated contact with TB patients. Okay. In between this, there are another set of people who are called underserved people. Underserved people are those who have limited access to the quality TV service, and they include illegal immigrants, refugees, children. They are come under underserved people. Okay, let's see about TB preventive therapy also. It is usually given to a high risk group of people. Who are high risk group of people as usual? HIV patient, TB contacts, and immunosuppressed individuals. And it is given to prevent the latent TB becoming active. So, what are the regimens available under TB preventive therapy? There is a short course C. There are shorter regimens for 3 months, 1 month. 1 month there is isoniazid and rifampicin, and 3 months also there is isoniazid, rifampicin, and another 3 months course is like isoniazid and rifampicin. Whenever we started TB treatment, before that we have to diagnose whether they have any resistance to any drugs present. And the TB preventive therapy ensures the better health for the risk group people. They reduces the TB spread and its complication, and it's always mandatory to check the side effects because isoniazid has a liver toxicity, so it is always mandatory to check the side effects. And the total for any therapy there should be an adherence to the course. What are the drugs they are giving? They should follow it completely, and they should not stop it in between. Thank you.
Was a good presentation, and visually the poster was so good. The color option is very good, and the pictures you upload is really good. So good on that. But while presenting regarding the TPP, I think you have kept it short, so that you would have concluded in a paper.
Okay.
So that was one part. And the introduction was too much of introduction regarding your.
Okay. Thank you. Thank you, Divyadashri, and thank you, judges. Next, I would like to call upon TB Day to present on the topic World TB Day.
Good morning, all. I'm here to present a poster on World Tuberculosis Day. World Tuberculosis Day is observed annually on March 24 to raise awareness and support efforts to eliminate tuberculosis. Tuberculosis is a contagious disease caused by Mycobacterium tuberculosis. Promote early testing and screening to identify tuberculosis cases before they spread or become severe. We can prevent tuberculosis transmission by getting vaccinated and following the infection control measurements. Improved healthcare system by strengthening the healthcare infrastructure, better access to diagnostic tool, medication, and healthcare services. The TB cases gradually has been increased from 2020 to 2023, but 1.5 lakh cases is reduced in 2024. The tuberculosis elimination program has evolved significantly over the years. In 1962, the National TB program was launched to provide tuberculosis diagnosis and treatment, but it faced challenges due to limited resources. In 1997, the revised National Tuberculosis Control Program introduced the DOTS strategy for better treatment adherence. In 2012, National Strategic Plan for Tuberculosis Control focused on universal access to tuberculosis care, including the multi-drug resistant treatment, tuberculosis treatment. In 2020, the National Tuberculosis Elimination Program, it was renamed to NTEP, emphasizing the more patient-centric approach with diagnostic tool, private sector engagement, and active case finding. And concluding with the theme of 2025, yes, we can end the TB, commit, invest, and deliver. Thank you. Directly observed treatment short course strategy. Like analyzing the course of treatment, whether you're taking the tablets or not, they will have a closer look on it by contacting you. Yes, yes, ma'am. Yes, ma'am. Yes, ma'am. Ma'am, it was changed in 1997. Yes, ma'am. Address Chennai. Keep. Thank
Thank you. The next scene will be Tagore A on the topic extrapulmonary TB.
Good morning, madam. And I'm Kadipir. I'm a female Panagapriya, Kanishka, and Bhartigayan. We make a post around extrapulmonary TB. And TB is most commonly affected in lung, but also affected in the extrapulmonary area. And so it affected from head to toe, except the hair and nail bud dark. And it is affected in 15 to 20% in the immunocompetent patient and 50% in immunocompromised patient. So the most common type that TB can affect is meninges and TB, lymph node, and pericarditis and spinal cord and genital tracts also. And the diagnostic part, it is a two part and clinical and microbiological aspect. In clinical, we check the patient is also already exposed to TB or the patient to the drug resistant and treatment failure, post therapeutic loss. And in microbiological aspect, we done the CB It is a molecular method. It is most commonly used for the identify the rifampicin resistant. It is a TB sensitive to rifampicin or resistant, and the treatment part is a two phases there, and intensive phase and continuous phase. The intensive phase its duration is 2 months, and continuous phase is 4 to 6 months. And in intensive phase, the bacteria is killed rapidly, and the continuous phase it is killed the remains bacteria. Intensive phase is prevented resistant to the drug, and continuous phase it is prevented their lapse. The most common regimen in intensive phase, we used the isoniazid, rifampicin, and pyrazinamide, ethyl butyl. In continuous phase, if isoniazid, rifampicin, and ethyl butyl is most common regimen. The duration for the new extrapulmonary TB, the most the teeth include abdomen and pleural and pericardial, urodata and female genital tract and cutaneous. These are the case. The treatment duration is 6 months, and ocular and ENT involvement. We give them treatment in 6 to 9 months. The CNS and bone and joint involvement. We give the treatment duration is 12 to 18 months. The indication for surgery for the TB treatment, the complication in the retinal vasculitis and uveitis and non-resolved vitreous inflammation in the ocular involvement, and hydrocephalus in meningitis, phagocytic palsy and retropharyngeal abscess in ENT-TB, and pericardial tamponade. These are the conditions we give the surgical management. This steroid indication for the steroid is for the extrapulmonary TB, the medical involvement and pericarditis and ocular involvement. These are the conditions we use the steroid, but in pulmonary involvement we not use the steroid because it is suppress the immune response. So it is over than the condition. Oh,
Anyway, before it was, I think it was a very problem. And you have mentioned the evidence also. And regarding the genital TB, do you have some most common say in TB genital TB?
ovarian abscess. Ovarian abscess.
Common say?
Ovary.
There actually TB.
No.
Sure. What vaccine is it given? At birth, what vaccines will be given? Right.
Thank you. Next, I'm going to call upon Surya to present on the topic National TB Prevalence Survey in India.
Good morning to one and all present here. I'm Surya and I'm here to emphasize on the importance of the TB prevalence survey that we have to conduct to identify people with TB. So, what is the need for TB prevalence? We need to understand it first. So, to understand the importance of TB prevalence surveys, we need to understand how people can present with TB. So, there are two kinds from which people can present to you. It is microbiologically confirmed TB and subclinical TB. Microbiologically confirmed TB is the one that you confirm by doing microbiological tests such as interferon gamma release assay and sputum sample staining and etc. And subclinical TB is where the patients don't present any symptoms such as the classical symptoms that we hear every day, that is cough, chronic cough for more than 3 months, or night sweats, fever during the night times, which are all the common symptoms of TB. And the numbers you need to know that is about 50% of the people with TB are subclinically positive. So it is a whopping number. 2 in 1 suffers from subclinical TB, and TB prevalence survey helps us to find people who are subclinically TB positive. So here we have taken a sample time period of 2 years, which is between 19 and 21, where the TB infection rate for people above 15 years of age is 31%. And we need to understand that TB infection must not actually result in the disease TB. So TB infection is where you have the bacterium present in your system, but you don't have the disease actually. So all the high risk people such as we, the healthcare workers and people who belong to places where Mycobacterium tuberculosis infection is prevalent are the people in the high risk groups, and not necessarily they have to contact the disease, but the tuberculosis mycobacterium infection is the one which is more important to understand here. And 31% of people have this who are above the above 15 years of age, and from years 0 to until what age they have calculated, it is 41%. So as we all can see the pie chart, you can see where the incidence rate for India and other high burden countries are somewhat equal. So now we can all understand why we have been emphasizing on the importance of TB in the past 3 days. India is the hub of TB. So 1/5 of the population suffering from TB hails from India, as you can see, which is the total number of cases during 19 and 21 was 9 million cases. So 20% is approximately 1.8 million. So it is a really high number. So conducting surveys and identifying people who suffer from TB is the need of the heart actually. So the general population, the prevalence among the general population excluding high risk groups, that is the people who suffer from retroviral positivity, HIV, who can contact any disease easily, and people with diseases which can weaken the immune system such as blood dysplasias and lymphoma, leukemias, where they can contact any disease easily. So they are the high risk group people, and excluding high risk group people, the incident rate it has 36%. And the survey purpose, the survey is aimed to determine the actual disease burden of TB in India at a national level, and it was conducted for 20 individual states, which has been represented in the bar graph, as you can see there. And the challenges: frequent turnover in human resources, lack of survey participation. So people, when we go conduct surveys, people don't actually answer to us easily. So there can be people who actually have chronic cough or the classical symptoms of TB, but they may not necessarily report it to us. They may feel social stigma about us and they don't report to us. So these are the challenges and issues with X-ray machines and laboratory investigations such. And the key findings: the survey estimated the point prevalence of microbiologically confirmed TB, which we discussed earlier, among the people aged above 15 years, and estimated at 31%, as we already saw. And the implications: the finding emphasizes the need for targeted interventions and close monitoring to reduce the burden of TB in India. And I conclude by saying the slogan of the year to end TB, which is yes, we can end TB by committing, investing, and deliver. Thank you. First, the patient presents with chronic cough and 6 months. Three weeks. Chronic cough, night sweats, and evening rise of temperature due to cortisol levels in human body, and these three are the classical symptoms. Yes. Body weight and sickness. Yes. And the healthcare workers who have daily contact with patients of TB and people with the lower immune states, the children and geriatric patients. Yes. A mean of 199. Not sure about the numbers. Thank you for sharing the information.
Thank you. The next team will be Divya on the topic TB diagnosed. Okay.
Good morning to everyone present here. I'm Divya. I'm here to present my topic TB diagnostic modalities. As you all know what is TB and what is causing it, let's explore the various diagnostic tools and understand how we diagnose scientifically. The first one is first we have to see the objectives of ear detection. It helps to provide appropriate treatment and prevent further spread of disease and identify drug resistant cases. Diagnostic modalities. First, we see the microbiological diagnosis, which include sputum smear, then culture methods. Sputum smear, we use Z-Nielsen staining for specimen. Then culture methods, we are using LG medium and liquid medium. Liquid medium includes MGIT. Then radiological diagnosis, which includes chest X-ray and CT scan. Chest X-ray includes typical TB findings such as in-face infusion, then lymphadenopathy. In CT scan, we are using in extrapulmonary TB cases and in complicated cases. Then immunological tests, which include tuberculosis skin test, also known as Montauk test. Here it measures hypersensitivity. If the indication is 10 mm, it indicates positive for TB in immunocompetent patient. If the indication is 5 mm, it indicates TB positive for immunocompromised patients. But it cannot distinguish between active and latent TB cases. Interferon gamma this assay used to mainly detect latent TB Then histopathological diagnosis, which include biopsies of lymph nodes and other bodies fluids. Then appendix simulation, which shows granulomatous caseous necrosis. Then other diagnostic modalities include urine examination. It is recommended for HIV patients with low CD4 count. And here is the visual representation of the diagnostic modalities. The first picture is the active path baseline. Then second picture is the immunofluorescence dye. The third picture is LG medium, and the fourth picture is gene information. Then the fifth picture is chest X-ray, and the next one is CT scan. The last two are tuberculosis index and the drug susceptibility test. Then the duo methods and RMSP guidance include CPNAT procedure. What is CPNAT? Is Cambridge-based nucleic acid amplification test. It's also commonly known as gene expert. It is a rapid molecular test used for diagnosing TB as well as rifampicin resistant. That is based on the principle of real-time RT-PCR. There are both advantages and disadvantages in this procedure. Then let me tell the procedure. First, we have to collect the sample. The sample includes sputum, body fluids, and CSF. Then the sample is mixed with buffer reagent and is put into cartridge. Then the cartridge is inserted into the gene expert machine. Then where the DNA is extracted and amplified, and MTP is detected present, and alpha resistance is identified if there are mutations in RPOD gene. The results are available in less than 2 hours. And here is the diagnostic algorithm for pulmonary TB. If the patient is presented with TB that we are suspecting, we have to do smear examination and chest X-ray. If both are positive, we can conclude that it's a microbiologically confirmed TB. If smear examination is positive and CT is chest X-ray is negative, or both the tests are negative, we can do another diagnostic method, it's CBNAT. If CBNAT is positive, then there are 3 types of resistance in rifampicin. Then conclusion, your detection saves life. If you have a person cough, fever, or unexplained weight loss, you should get tested for TB today. And timely diagnosis leads to effective treatment and healthier future. With that, I would like to end my presentation. Thank you all.
Yeah, usually it is a intention. And what will happen? It would have been a proper balance. So you have to go with the balance. So that proper important. And the TB diagnosis. Before the student examination, how many student samples you will have?
2 samples.
Okay, before
Your thing.
and do you know that how to collect technique?
Thank you, madam.
Thank you. Now I call upon Aditya Rao to present on the topic CBNAT.
Good morning, my name is Aditya Arjay. I'm going to talk on the topic CBNAT. And so what is CBNAT? CBNAT is catalyst-based nucleic acid amplification test. It is a rapid molecular diagnostic test used for detection of TB and rifampicin in TB patients. Mainly prescribed by the ATP to use this. And major merits and demerits are: the merits is the investigation choice for both diagnosis and treatment for TB based on the CBNAT. And also, every TB patient will undergo a CBNAT test. After then only the treatment model will be preferred to them. And major limitation means the detection limit will be around 130 quantiferon unit per ml. Below that, we cannot sensitize TB in this machine. And next, in follow-up questions, we cannot use CBNAT as there will be dead bacteria also present in the sputum, so we cannot use it. And the next principle, and on what principle the CBNAT works is based upon the CBNAT detects the DNA specific to the MTBR, microbacterial tuberculosis, and then uh, it concentrates the bacilli from the sputum and then isolates the genetic material from the bacilli and then amplifies the DNA using the polymerase chain reaction. It also identifies the rifampicin system-induced mutation in the RPOB gene by the real-time format using fluorescent probes like molecular diagnostics. And next, important instruments and tools in the gene expert system. First, the instrument mainly the thermal and optical system, which is used for lysis and analysis of the sputum samples or the respective sample, and then the cartridge, which is single exposable and disposable, mainly contains the sample, and then the computers mainly for running the gene expert software and to hold the result database, and then comes printers and UPSC also mainly required for successfully running the test. And the major methodology is after taking the sample from the patient, we have to add a sample reagent maximum at the 2:1 ratio, and then allow it to liquefy, and then add the sample to the cartridge, and then scanning the barcode in the cartridge using a barcode scanner, and then starting the procedure. In the module of the instrument, when the green light starts blinking, I start the insert the cartridge and start the procedure. After 2 hours, the green light stops, which indicates that the test has been completed, and the result will be displayed in the monitor screen. And then, after completion of the test, we have to remove the cartridge from the dispose the cartridge from the system, and then I like to conclude the topic by based on saying that the NTEP is specializing of using CBNAT in most of the laboratories in our country, mainly for the extrapulmonary tuberculosis patients, for lymph node and other tissue samples from using the conventional methods like microscopy, culture, and something like that. And then it also useful in TB meningitis patients. Also, we can use the CSF sample. We can use to for the CSF sample examination. Also, we can use CBNAT for early detection rather than the culture and other old methods. Thank you. Based upon the site from where they take, for CSF, mainly for mainly in plastic. Mainly plastic capital for taking a different. Okay. Like lymph node and biopsy also we can use for CBNAT for extraordinary TB, and for TB meningitis patients we can use CSF. Yes, ma'am, around 2 hours approximately. Okay, thank you.
Thank you. The next presenter will be Raksha Bennett and her team on the topic IGRE.
Good morning to one and all present. I'm Raksha Bennett. I'm here to present a poster on IGRA. Although our poster has written, I'm pretty sure it has good personality. So IGRA is an in vitro test that tests the cell-mediated immunity
of the patient against the Mycobacterium tuberculosis by using an antigen that is specific to Mycobacterium tuberculosis. It tests for immunological evidence of sensitization against the by the interferon gamma release by the mononuclear cells of immune system. The antigens that are used are ESAT, early secreted antigen target, ESAT6, CFP10, that is culture filtrate protein, and TB7.7. There are two types of IGRA, that is quantiferon gold test and T-spot test. So quantiferon gold test, the processing of blood should be done within 16 hours, whereas in T-spot, the processing of peripheral blood mononuclear cells should be done within 8 to 30 hours. Also, the antigen used in quantiferon gold test is CFP10, ESAT6, and TB7.7, whereas in T-spot, the antigens that are used are ESAT6 and CFP10. In quantiferon, as the name suggests, it measures the amount of interferon gamma that is released, whereas in T-spot, it measures the number of cells that produce interferon gamma. So the interpretation is done based on number of interferon gamma, number of cells that release interferon gamma, and the concentration of interferon gamma that is released. It tells whether the patient is exposed to has been exposed to TB or not, and it does not tell whether they have an active infection or a disease. IGRA cannot rule in or rule out TB. So the advantages of IGRA is that the results can be availed in 24 hours and in single visit, and there's no interference due to secondary vaccination, and it's specific for TB. If the MARTO test is positive, and it can be positive due to Mycobacterium tuberculosis, Mycobacterium bovis, or other non-tuberculous Mycobacterium. If MARTO test is positive, IGRA can be done. And if the IGRA is positive, it can be due to latent TB infection. And if it is negative, we can think it is due to a non-tuberculous Mycobacterium infection. So, and the cons is that IGRA is very costly. It's costly for people in India. And NTP has been taking measures to make it affordable for us. And I cannot differentiate between active versus latent infection. And there's a requirement of meticulous blood collection and processing, because if there's any difference, the results could vary. And there's no prediction that the patient will have a active TB in future or not. And there's very limited data for patients less than 5-year-old, and for immunocompromised patients, and in patients who are recently exposed to it. And the role of IGRA is mostly in 5 to 15-year-olds to look for a latent TB infection. And the specificity of T-spot is greater than the quantiferon gold test, and the specificity decreases as in HIV patients and in children, and the sensitivity, it increases with age. Like for less than 2-year-olds, the sensitivity is 80%, and for 2 to 5-year-olds, the sensitivity is 91%, and more than in 5 to 18-year-old, the sensitivity is 96%. So the IGRA is mostly recommended for children above 5-year-old, and MAN2 test is used for children less than 5-year-old, and when IGRA is used, treatment should precede diagnosis. So thank you.
So you told it's medical diagnostic and active TB. So what is the difference between the latent and active TB?
In active TB, there's active production of antibodies against TB, and latent TB, there's a presence of presence of like there's no clinical symptoms, and how do you expect? Sensitive in the sense like Thank you.
Thank you. Next, we call upon Raj Sadiq to present the topic scientific.
Good morning to everyone. I'm Pratik Ragi with my teammates Rishka, Reshma, Ravi Roshan. I am going to present here CYTV. It is a skin test. It is an antigen-based skin test which detect the latent in TB infection. Latent if any person having infection, but that person didn't having the active tuberculosis any symptoms, then we can call it as a latent TB infection. It is very difficult to detect. That's why we're using CYTB. CYTB is an antigen-based test. In antigen, there are two types of antigen which are secreted by the Mycobacterium tuberculosis. First one is ESAT6 and second one is the TFP10, which are the specific secreted by the Mycobacterium tuberculosis. And this we use for that we use a recombinant DNA technology to we use a recombinant DNA technology for CYTB test. Now I am going to introduction. It is diagnostic tool used for the determination if patient exposed by the Mycobacterium tuberculosis. Objectives are novel test recommended for the detection of the TB infection under the National Tuberculosis Elimination Programs. There are methodology for the CYTB. First one is preparation before the administration. Second is the administration into the skin and reading the reactions. First one, before the administration, there are where is the manufacture of the CYTB vials? They have to we have to transfer that vials to the PHC by the cold chain methods. For administration of the skin test, first one is the injection. A small amount of purified protein derived is injected just under the skin on the forearm. Reading the test, if a person injected with the CYTB, doctor have to call that patient after the 48 to 72 hours because of it will show the delayed type of hypersensitivity. Indicates it indicates the person has been exposed to the TB bacteria, so it does not necessarily means that person having the active TB infection. Results, it is university 5 mm cutoff has been established for CYTB, which indicates infection with tuberculosis. The measure the diameter with the scale. If intuition is more than 5 or 5 mm, we call as a positive. Some advantages of the CYTB: high specificity. It is more specific than the tuberculosis test because Mycobacterium tuberculosis is secrete two antigens, ESAT6 and CFP10. It is also point test, easy for administration, no sample handling. In IGRA, we have to handle samples, but in CYTB, there is no need to handle any samples. It is a universal cutoff, universal 5 mm cutoff. Point of induration used regarding the of BCG. Conclusion is CYTB is the best and specific test for the diagnosis method for detection of a TB. Thank you. Actually, in while the 1 ml will come,
Actually, the TB
Yes.
schools we are sickness we are looking to review. And how many people are going to know the picture populations? You are not by the model, they are taking one and that dynamics within false possible.
Yes. Yes.
How is information? It's that voice. I think. Internet, small amount of people. What is it? Small things.
Zero.
0.05 of them people. Think for our diversity. So some people they check every you think about like for those people, they will be false positive. So we should have also write in the how many people are in skills are practically by micro realization. So if you are like from all the time there is a infection. What I want to do is that
Then we have to, ma'am, we can give uh, if there is a latent infection means we can TPT regimen we can test. False negative if majority nowadays we are giving PCG vaccine, ma'am. Then in that PCG vaccine, if now tuberculosis test now there is more chances to give false positive. False
there
negative.
is TB infection, but there will not be any darkness body information or any formation of the savings.
And there is if we have other infections. If there is other infections, Rosen's phenomenon.
It's like, people like
Inside, yes.
they are they won't get and also ignore all the different solutions feel reaction. Ignore moderate patient which won't get any. We have bad patients.
Thank you.
Thank you. The next team will be Priyadashini on the topic integrated TB diagnosis algorithm.
Good morning, everyone. I'm Priyadashini, and my team members are Pravin, Priya, Preeti, and Punita. And today I'm going to present the topic on integrated TB diagnostic algorithm. So, as we all know, tuberculosis remains as a major global health issue, and early diagnosis is a key to avoid its spread. But here is the challenge: many cases go undetected and somewhat misdiagnosed, which leads to delayed onset of treatment and development of drug resistance. So this algorithm helps us to tackle these problems by combining the clinical evaluation with the microbiological test, with the molecular test and imaging, that way giving a precise and rapid outcomes. So that's the objective for this session. We will get into it. So the first thing is to identify the presumptive TB patient. Presumptive TB patient or someone who is having persistent cough, fever, night sweats, weight loss, or recent contact history with the TB patient, or the iris groups which involve people living with HIV and other immunocompromised state. So once presumptive TB patient is identified, then we perform sputum smear examination and chest X-ray. If sputum smear is positive, irrespective of the chest X-ray, then TB is confirmed. Whereas if sputum smear is negative, it doesn't rule out TB. We need further diagnostic test to confirm it. That's where TB NAT comes in. TB-NAT, cartridge-based nucleic acid amplification test, is a powerful molecular test that not only detects TB but also determines its resistance against rifampicin. So once TB-NAT results are out and the MTB is detected, we immediately do the sensitivity for rifampicin. If rifampicin is sensitive, we will go with the standard TB treatment available. Whereas if it is resistant to rifampicin, then we have to do the further drug susceptibility test to find out if it's resistant against other first line and second line drug resistance. And also, if the sensitivity test is inconsistent, that is intermediate, then we need second sampling of TB-NAT. And if it's still indeterminate, then we have to do a sputum sample for liquid culture or line probe assay, where even a minute amount of microbes will be detected, hence no cases will go undetected. And also, TB will not always present as active. In some cases, the patient will present with latent TB. Latent TB patients are those who are infected but not yet sick. They are asymptomatic. So for those cases, TB can be diagnosed with the help of IGRA, interferon gamma release assay, and also with the help of the skin test, that is the Montec test. And if the TB-NAT results are not conclusive, not available, then we will go with alternate diagnosis, mostly TB diagnosed clinically if the results are not available. So, on conclusion, this algorithm, this structured algorithm helps us to detect the TB faster and more accurate, and better detection for the severe negative cases and the drug resistant cases. Early treatment is underwent so that we can prevent the complications and avoid its spread, and better patient outcomes. And to conclude with, hence we say if we know TB early, we can. Hence we say if we know TB early, there will be no TB. Thank you.
There are been presentation of here and
Cartridge-based nucleic acid amplification test.
something similar to CP-NAT.
TrueNAT.
What is the finding?
Here only resistant to rifampicin can be found, whereas in TrueNAT we can find the resistant to isoniazid also along with rifampicin. And CP-NAT takes 2 hours for the results, whereas TrueNAT the results will be get by 1 month. PMDT is programmatic management of drug resistant TB. Thank you. Thank you. Now I call upon Shweta Senthilkumar to present on the topic intensified case finding.
Good morning, everyone. So I'm Shweta. I'll be presenting about intensive case finding today. My team members are Shweta P, Tulasi Raman, Tejashwini Yuva Jaisudha, and my mentor is Dr. Shweta. Okay, so what is intensive case finding? Intensive case finding is basically a proactive approach for early detection of TB in high-risk population and to prevent the transmission and morbidity, mortality adena. So simple as solona, intensive case the patient when coming to us won't come with symptoms indicating TB, but we still do TB screening in them. That is called intensive case finding. This is different from active case finding and passive case finding in the sense that active case finding now we will do community outreach. We will go door by door and we will screen for TB in high risk population. Passive screening now we will the patients will come to us with a lot of TB symptoms. But when we do intensive case finding when the patient is not even presenting for TB, but we still screen them. This is what intensive case finding is. Now, why? Why do we do intensive case finding? The importance is that we can detect it early and we can prevent transmission, prevent morbidity, mortality, and all that. The thing is, almost 200 people per lakh population in India have TB, and there's 3,000 mortality rate per day. So, with such a high number, it's very important that we do intensive case finding and detect it early. So, this was the importance. Now, who do we do high risk intensive case finding for? We do it in high risk populations, such as immunocompromised people who have diabetes, HIV, then prisoners, slum areas, because they have more poor sanitation hygiene. Apart from that, yeah, these are the high risk populations we screen for TB for. Now, how do we do intensive case finding? The diagnosis part of this is basically when we encounter such high risk population, especially HIV, because HIV and TB kind of occur together almost. They have a presentation together many times. So with such people, we do symptomatic screening. Symptomatic screening, there are 4 main symptoms of TB. That is your reproductive cough for 2 weeks, night sweats, weight loss, fever. If there's even one symptom of this in a HIV patient, we will screen them for TB as a rule. This is the intensive case finding in HIV people. Apart from this, the normal diagnostic modalities, that is a sputum smear or chest X-ray, if there's any X-ray chest X-ray abnormalities, then we will do sputum smear and we see if there's an acute fast line which is present. Sometimes what happens is sputum smear is negative, but the person will still have TB. This occurs in when the patient has it's in the early stage of TB. So for them, we can suggest CBNAT or gene expert. So that this is basically a molecular amplification technique. Through this, we will be able to amplify and identify TB cases even more early, even if the sputum smear is negative. So this was the diagnostic part. As a conclusion, intensive case finding is at the need of the hour because we have a lot, as India is one of the major burden for TB, it's really essential that we screen TB early in high-risk populations and prevent the transmission, morbidity, and mortality.
You should start taking action.
Now we should start ADT treatment before HIV treatment. Otherwise, they will fail.
If patient has actually positive, then you should start.
We should start TB treatment first, not HIV.
Why?
Because then the HIV patient might get more immunocompromised and presents with worse symptoms. So we should always treat the disease first before treating HIV.
If you start first IR treatments and then you are starting things, what will be done?
They will have HIV people will have present with they'll get more complicated, they'll go more immunocompromised and they're present with more severity.
What are treating?
Antiretroviral.
Antiretroviral. What will we do for it? It's not this. The vaccine was we should be started before IR. But what the we should start not governing by this. What they are doing, think you should start entire meetings. Like this is we could start like prophylactic condition before activity. You should start it.
And there are like
Like all the contest and all things. So what the contest?
there are like 5 types. So one is if there is no acid pass backline 100 microscopic views, it's negative. Then now then if there is 1 to 9 or 1 to 10, then it's one grade in 100 microscopic views. Then 1 to 10 in 1 microscopic view is 2 grades. Then 10 to 99 in 1 microscopic view is 4 grades.
Thank you. And the last team will be Ovia and the team on the topic 100 days campaign.
Very good morning to everyone. I am Ovia. I'm going to represent my team, including Pavya, Pumagal, Padmashri, and Pradesh Kumar. And I thank my mentor Sharmila ma'am for guiding us. And my topic is not 100 Days TB campaign. So, what is 100 Days TB campaign? It is a type of active case finding in tuberculosis, and it is a decisive step towards ending tuberculosis, which was launched by Shri Jagat Prakash Nadda, Union Minister of Health and Family Welfare, on December 7, 2024 in Panchkula, Haryana. And it was successfully ended on March 24, 2025 on World Tuberculosis Day. And what are the aims of the 100 Days campaign? The first one was there should be early case finding. And second one was there should be reducing in delayed diagnosis. And the third one was we should enhance the treatment for high-risk group peoples. And the theme for 100 Days campaign was TB Mukht Bharat through Janbhagidari. What is meant by Janbhagidari? It is community participation. And we this 100 Days campaign, which includes the 4 phases. The first phase was awareness and motivation. In that, we will create awareness among the peoples about what is TB, and the theme of this phase 1 was to end TB stigma and promote the early diagnosis. And the phase 2 includes the active case finding. We will go and identify the undiagnosed TB cases, and we ensure the timely testing. And the third phase, which includes the diagnosis and treatment initiation, confirm the diagnosis and provide treatment and ensure adherence. And the phase 4, which includes the monitoring, evaluation, and feedback. The objectives of this phase 4 was track campaign impact and ensure the follow-ups and reward successful efforts. And in phase 1, we are going to see what are the days that are included in phase 1. Day 1 to 2, we are going to launch the campaign officially, and from date 3 to 7, we are going to conduct awareness among the people in the community about the TB. And in day 18 to 14, we will, as we doctors, we are going to create door-to-door awareness about the TB. And on day 15 to 20, we are going to spread the awareness through the mass media such as Instagram, Twitter, and Facebook. And on by this, the phase 1 ends. And the phase 2, we are going to find the active case finding and screening. For this, from day 21 to 30, we are going to set up the diagnostic camps among the community. And from the day 31 to 40, we are going to collect the free sputum collection, which was done by we are going to train ASHA workers for this work, and we are going to implement the contact tracing to the TB patients. And from day 41 to 50, we are going to do early diagnosis through Gene Expert, and we should ensure a proper record using Nikshay portal. On phase 3, we are going to do diagnosis and treatment. On this, in the beginning of day 51 to 60, we are going to confirm all suspected TB cases, and we are going to provide a free medicine using Nikshay Poshan Yojana, in which TB patients will receive rupees 500 per month for nutrition support. And for day 61 to 70, we are going to offer counseling services and monitoring the signs for TB drug resistance. And for days 71 to 80, we are going to give establish peer supports for the patients. And from by this phase 3 is going to end, and on phase 4, we are going to monitoring, evaluation, and feedback. In this, from day 81 to 90, we are the treatment tracking provided in centers. So we are going to tracking the treatment whether it was done in good or not. And day 91 to 95, we are going to evaluate the campaign impact. And by the day 96 to 100, we are going to recognize the achievements which was ended on March 24 on World TB Day. And thank you. By monitoring the patients, we are going by van.
Listed out a series of activities, right? And some activities, we also need some activities.
Door-to-door awareness.
We conducted a rally. Rally we conducted, right, with the second year students. Now, we noticed that, no. And we have also had one sessions also, after it is also like, and
Yeah, very unique way of presentation, and you have put in lots of efforts. Thank you to see that. And the 100 days regarding 100 days campaign, it started from when and it ended.
It started from December 7 on 2024, and it ended on March 24, before 3 days in 2025, March 24.
70. 100 days race. And regarding actually, Kosher also mentioned like this 500 per month. And it got updated 40,000 without that. Is there any online web portal?
Nikshay portal is available for enrolling the patient's name and what are the treatment. We will track on that. Patients will be receive an ID. Through that, we can track the patient's treatment and what are the conditions of the patients and what are the treatment we are going to give a patient.
Then any specifically support the community participation.
In Tamil Nadu.
Also,
காசு நோய் இறப்பில்லா திட்டம். காசு நோய் இறப்பில்லா திட்டம் was launched by Indian government.
there's something called the
With this, we conclude the first section on TB diagnosis. I thank all the participants for their active participation. I would like to invite Dr. Gayatri ma'am and Dr. Anushandani ma'am onto the stage for announcing the results. I request all the participants on the TB treatment to come and occupy the front seats. Malasi, Harsha, Yuvashi, Gauri, Akshaya, Ananya, Bharat, and Harini. Mirza, Kaushik, Shrutika, Shalini, Sindhuja, Kavin, Naveen Raj, Pratiksha, Shobika, and Varshita. All of you kindly occupy the front seats.
First time.
So the overall presentation was so good, and it's happy to see you presenting like this. Concluding with the first part of Pinky's presentation, the first prize will go to Shweta and Go.
Hello, Srikanth. Where are the kids?
Chat by icon also. And he gets the name.
Two plus three.
It's got many it's like that. Oh yeah.
The presenter along with all the participants and companies.
Sorry, I'm sorry if you very got it better. It is just lost. Treatment.
Thank you, ma'am. The next topic will be TB treatment, and I invite Dr. Fatima to be the reviewer. And Dr. Isabel. The first presenter will be Manasik Ji and her team on the topic dogs. The reviewers will be Dr. Ishani Ma'am from Department of Community Medicine and Dr. Ishani Ma'am from Department of Aesthetics.
Good morning, everyone. I'm Manasi, and my team members are Lakshana, Lakshmi Shweta, Neelambika, and Lakshmanan. I'm here to present a poster on the topic DOTS. DOTS stands for Directly Observed Treatment Short Course. So it is a strategy which is recommended by RNTCP, which is Revised National Tuberculosis Control Program, which is now renamed as NTP, National Tuberculosis Elimination Program. So it is a systemic and cost-effective strategy. So in DOTS, the healthcare provider or any trained individual watches the patient take the medication, which ensures proper adherence. So there are 5 key components of DOTS, which includes political and financial commitment, case detection using sputum microscopy, uninterrupted drug supply, monitoring and evaluation, and standardized treatment.
I'm Lakshana and I'm here to debrief the points. So political will is necessary to ensure funding infrastructure and to fund proper manpower and to implement and formulate policies. For case detection, all the presented TB diagnosis undergo sputum sphere microscopy. 2 samples are collected, one in early morning and one on-spot samples. And the cases are categorized in 3 categories. Category 1 are new sphere positive cases and extrapyramidal TB cases. Category 2 are relapse cases and drug failure cases, and category 3 are drug resistant cases. A standardized treatment using DOT strategy is followed where during the intensive phase, the healthcare worker or a trained professional individual watches the patient swallow the drug, and during the continuation phase, the patient is issued with the medicine of multi-blister combi pack, in where the first dose is swallowed in front of the healthcare worker, and the intake of the drug is monitored with the return of the empty multi-blister combi pack. Then the patient returns for the refillment of the medication. So adequate drug supply should be maintained. Primarily, 4 drugs are used in the treatment of TB. Those are isoniazid, rifampicin or rifabutin, ethambutol, and pyrazinamide. For drug-sensitive cases and drug-resistant cases, the duration differs. And for mono-drug resistance and polydrug-resistant TB, linezolid is used and rifampicin, pyrazinamide, and ethambutol is used. A newer strategy called DOTS plus is followed for multi-drug resistant TB, where B-PARM regimen is followed using the drugs bedaquiline, pregabalin, linezolid, and moxifloxacin. It is given for 6.
So all the diagnosed TB cases, they are registered under a portal called Nikshay portal, where the individuals are assigned a unique identification number to review their progress. The non-adherent cases, they are flagged and they're managed through counseling and follow-up. So another newer monitoring method is 99 DOTS. It is a low-cost and simple approach for monitoring TB. So according to this, patient is given a multi-blister packet, which consists of 28 pills and a hidden toll-free number. So as soon as the patient takes the medication, they make a call to the toll-free number, which ensures like proper monitoring of their progress. So DOT strategy has a great significance in preventing the drug resistance TB, increasing the cure rate, and it also reduces the TB transmission. So I'd like to conclude by saying that since effective treatment abolishes the cycle of transmission, so cure is the best prevention, and DOTS forms the basis of TB control and prevention.
DOT strategy was initially found in 1996. The DOTS plus is primarily used to treat drug-resistant cases, wherein DOTS is used to treat normal drug-sensitive cases and relapse cases, primarily the drug changes.
Thank you. Next, I call upon Harsha Sridhar to present on the topic TB drug groups and side effects.
Good morning, everyone. I'm Harsha, and I'll be presenting on the topic TB drugs and its side effects. The introduction of tuberculosis drugs has been a significant advancement in the management of this disease. As we all know, TB is a highly contagious and potentially fatal disease. The objective of this presentation will be to have an overview of the group of drugs, their mechanism of action, and the key side effects. So let's look at the group of drugs. There are primarily 5 groups of drugs, groups 1, 2, 3, 4, and 5. Group 1 includes the first line drugs isoniazid, rifampicin, ethambutol, and pyrazinamide. Group 2 includes the injectable antitubercular drugs that includes streptomycin, kanamycin, amikacin, capreomycin. Group 3 includes fluoroquinolones, which includes ciprofloxacin, ofloxacin, levofloxacin. Group 4 includes oral second-line antitubercular drugs. That includes ethionamide, prothionamide, cycloserine, para-aminosalicylic acid. And group 5 are miscellaneous drugs. This includes clofazimide, linezolid, amoxicillin, clavulanate. Let's look at the mechanism of action of the key drugs. I'll start with isoniazid. Isoniazid acts by inhibition of the myconic acid synthesis. Rifampicin inhibits the RNA synthesis, and pyrazinamide inhibits the membrane transport energy. And ethambutol inhibits the cell wall arabinucleic galactan synthesis. Streptomycin is not a commonly used drug, but it is a part of the first line drugs and it inhibits the protein synthesis. I will also show the key side effects. Rifampicin. Rifampicin produces reddish-orange discoloration of the secretions. Isoniazid will cause peripheral neuritis. Pyrazinamide will produce phototoxicity. Pyrazinamide will cause hyperuricemia and produce gout. Ethambutol will cause visual problems. There will be a decrease in your visual acuity. There will be red-green blindness. And finally, streptomycin will cause phototoxicity, nephrotoxicity, and shortness of breath. I'll give you a brief overview of the regimen in the treatment. There are 2 phases, intensive phase and continuation phase. Intensive phase is for 2 months and the continuation phase is for 4 to 6 months. The intensive phase consists of 2 HRZE, which is 2 isoniazid, rifampicin, pyrazinamide, and ethambutol. The continuation phase is 4 HRE, which is 4 isoniazid, rifampicin, and ethambutol. There are 2 new types of TBs well known, MDR-TB and XDR-TB. The regimen used to treat MDR-TB also has the intensive and continuation phase. The intensive phase consists of levofloxacin, ethionamide, ethambutol, cycloserine, kanamycin, and pyrazinamide. The continuation phase consists of levofloxacin, ethionamide, ethambutol, and cycloserine. I'd like to conclude by highlighting the importance of drugs in the management of tuberculosis. They're used as a combination therapy to reduce the resistance, to reduce the toxicity, and shorten the course of treatment. Thank you. Because when drugs are given individually, we can develop resistance to the drugs. So they're given as a combination to reduce the development of resistance. And drugs, when administered individually, can also produce increased toxicity. So to reduce the toxicity of the drugs, we give it as fixed dose combination. And also for the ease of the patient, there will be a better patient compliance if we give it as fixed dose combination. Yes. It's not deep. It's INH. What do you think? It's a program or an active? It's a program. What is it? It's a program. Yes, we can active one day. Interaction with the also, what is it? Why they are using that word H? R for rifampicin, R as a why they are using H for isoniazid?
It is a high some important.
Thank you. The next presenter will be Akshaya and the team, sorry, USP and the team on drug susceptibility test.
ஓகே இன்னும் கொஞ்சம் ஜூம் கண்ணு தெரியும் சார் ஆக்சுவலி ஜூம் பண்ணணும்னா இப்படிதான்டா வரும் இதுலதான் பண்ணிக்க முடியும் பண்ணி கீழே சரி கீழே நீ வந்து ஸ்க்ரோல் பண்ணிக்க எப்படி வரும்
I'm Yuvashri. I'm here to present on the topic drug susceptibility test. With the rise of extensive multi-drug resistant tuberculosis and extensive drug resistant tuberculosis, it poses a challenge to the public and medicine. So, with various antimicrobial drug and therapy available, the drug susceptibility test is vital to select the correct therapy, and also it also detects the resistance against rifampicin and isoniazid and various other drugs. So it also improves the TB management on whole. And the main objective is to select to determine the in vitro susceptible for the resistant drug to isolate the first line and second line TB drug, and also prevent and control the disease control. And the word drug susceptibility refers to the ability of the microbe to be killed or have its growth inhibited by a specific antimicrobial drug. And the word susceptible refers to it's actually a specific index for diagnosis accuracy. So we have two methods in drug susceptibility system testing: phenotypic and genotypic method. In phenotypic method, we have disk diffusion method, agar dilution method, and phage pass plague test, and various other automated systems like Vitec and microscan. In this diffusion method, a zone of inhibition is created by the antimicrobial drug if the drug is effective, and in agar microdilution method, the agar plates is inoculated with the bacteria based on the concentration of the drug. And in fast plague test, it is original macrophage coded. It uses the microbacteriophage to detect the resistant tuberculosis directly on the specimen, and various other automated systems include Vitec and microscan. In genotypic method, we have PCR, NAT, and CDNAT. PCR, it detects the genetic sequence in vitro to be amplified such that a particular genetic sequence can be imagined and visualized. The gene is specific and species specific. And in NAT, it is nucleic acid amplification test, and various other amplification tests include transcription mediated amplification. In NAT, it detects the genetics sequence and also resistant to rifampicin based on a particular system known as CPID gene express system, and it detects the genetic mutation specifically in a particular gene known as RNA polymerase OB gene. And in phenotypic method, as you can see in the So as you can see in the picture, in phenotypic method, So as you can see in the figure, we have a serological method, which is a phenotypic method to detect TB, and DNA is extracted, and the particular fragment is amplified, and it is used against the particular crop, and signal is produced. This is line probe clustering, and so the difference between genotypic and phenotypic method is it detects the genetic mutation associated with the drug resistance, and in phenotypic it only detects based on the microbial growth, and cost is higher in genotypic method, and the phenotypic method is low, and sensitivity is higher in genotypic method, and phenotypic method is lower. So what I conclude is it is vital for to provide a proper therapy in TB diagnosis, and also combined approach of both phenotypic and genotypic approach. Phenotypic method is slow and also it delays the treatment, whereas in genotypic method, it should be standardized, and it should also be globally used method because it is very effective. And I would like to thank my team members, Vaishali, Vipansi, and Yashwant Kumar and Vijayakshmi, and our mentor Nancy, for providing this opportunity. Thank you. Tests, we have distribution tests, and agar dilution method, and also pass slave test, and broad dilution, micro dilution test. And in genomic test, we have genotypic test, we have PCR, NAT, and CBNAT, and the various tests. I see. What are the we see isoniazid, rifampicin, and also a few other electrons. What we see rifampicin, we see RBOBG. One isoniazid, we have 2G. RNA format A and
Thank you. Next, we call upon Akshaya R to present on the poster drug sensitive TB.
Good morning to everyone present here. I'm Akshaya Har, here to do a presentation on drug-sensitive TB. So what is drug-sensitive TB? So drug-sensitive TB refers to the TB infection where the bacteria are susceptible to the first-line anti-tuberculosis drugs. The objective of this presentation is to assess the drug susceptibility patterns of Mycobacterium tuberculosis, to identify the prevalence of multi-drug resistance and extensively drug-resistant stains, and to determine the efficacy of the first and second anti-TB drugs. So what are the first-line anti-TB drugs? Isoniazid, rifampicin, ethambutol, and pyrazinamide. So the treatment that has been prescribed by NTP, which is National Tuberculosis Elimination Program, it's being split into two phases: the intensive phase and the continuous phase. The intensive phase is for 2 months, where the drugs prescribed are isoniazid, rifampicin, ethambutol, and pyrazinamide. For the continuation phase, the drugs are prescribed for 4 months, and the drugs are isoniazid, rifampicin, and ethambutol. The diagnostic criteria which we mainly use in drug-sensitive TB is PCR-based gene expert, CBNAT, which is also similar, and chest X-rays to see if any consolidation is seen, and sputum smear microscopy. The drawbacks and challenges we mainly face is that despite effective treatment, TB control faces challenges because of non-complaints from the patients, and then delayed diagnosis, which can lead to drug-resistant TB. and side effects from the drugs prescribed. So public awareness, pre-TB treatment programs, and newer research into shorter regimes and to use TB vaccines is very essential. So I conclude by saying drug-sensitive TB is curable and preventable disease when diagnosed early and treated appropriately. With adherence to the accurate regime, which consists of the four porphyrin anti-TB drugs, patients show full recovery. Early detection, patient compliance, and public health measures, if taken appropriately, can prevent this conversion of the drug-sensitive TB to drug-resistant TB. Thank you. My teammates are Akhilandeshwari, Aishwarya Vasudevan, Aishwarya Alice, Akash, and myself. Akshaya.
Nobody looks right. They're making progress. You have to take it. Somebody looks. Why are you
I'm not sure of my answer, but I think if the physician can see when they're taking it and then to prevent the side effects, to keep it minimum. The concentration at which the drug does not get rest.
Before I know, we can interview that patient. So we need 3 days now. So what is the basics we can test?
No, sorry.
What is the basics we can test? Intermittent treatment.
So in intermittent, it is to make sure that the patient takes the tablets when the physician can supervise them, and so that they give the body the time to go through those side effects and to make.
Most things happen due to which they have changed daily. So on lab phase, different basis of lab phase, one thing is their selection, each class and that period. So each comes to lab of lab period. So if we have like not issues, not basis, then we contribution to the lab for some drugs. Some drugs will get for mostly it's a great action to
Thank you. Next will be Anurani and the team on the topic drug resistant TB.
Good morning to one and all present here. I'm Anurati and I'm here to assist our poster, drug-resistant tuberculosis. So drug-resistant tuberculosis is said to occur when the tubercle bacilli is resistant to at least one of the first-line drugs. So it is a more complicated and a severe form because the prognosis is also worse. And moreover, the treatment is for a longer period of time when compared to the normal tuberculosis, and it has several side effects also. So the first drugs used are the isoniazid, rifampicin, pyrazidamide, ethambutol. So there are different types of resistances that we encounter: monodrug resistant, polydrug resistant, multidrug resistant, and extensively drug resistant tuberculosis. So monodrug resistant is said to occur when the tubercle bacilli is resistant to isoniazid, isoniazid, and rifampicin, which are some of the important first-line drugs. And excessively drug-resistant tuberculosis is resistant to all the second-line injectable drugs and fluoroquinolones apart from the first-line drugs. So, the treatment for the multi-drug-resistant tuberculosis occurs in 2 phases, that is the intensive phase and the continuous phase. So, the intensive phase is for about 2 months and the continuous phase is for about 4 to 7 months. So, intensive phase mainly aims at rapidly reducing the bacterial load, prevent the resistance, and improve the symptoms. So continuous phase is about eliminating the remaining bacteria, prevent the relapse, and ensure a complete cure. Treatment for the excessively drug-resistant tuberculosis is more complex, it's often longer also, and it's often less effective. Drug resistance mainly occurs because of the patient incompliance to the treatment and poor quality of the drugs that are prescribed, and also the incorrect prescription of the drugs. So symptoms are several initiatives are taken to prevent this from happening. One such is the DOTS. DOTS is directly observed treatment short course. A DOTS provider sees to that the patient takes the drug in front of him. So the symptoms are similar to that of the normal tuberculosis, and the diagnostic methods are antibiotic susceptibility testing and gene expert mainly. The prevention of the drug-resistant tuberculosis include complete treatment as prescribed prescribed and infection control and early diagnosis. Finally, the global efforts focus on shorter treatment, newer drugs, and improving the patient adherence for a better outcome.
Public qualification, when you receive the patient, you come after the complaint, the post will be different. Maybe or extra
Levofloxacin, kanamycin, cytosine,
so now another freshman all over drugs.
levofloxacin, cytosine, ethambutol, and
Even as patient. Now, who people drugs are being what that is. So what is their group?
Group A includes the first-line drugs, IGS drugs. Second-line injectable drugs.
Second-line drugs. Group A, Group B, Group C, Group D. Group A drugs. Thank you. Next is called upon Bharat to present on the topic MDR.
Good morning, my respected seniors and my friends. I'm Bharat and I'm excited to introduce myself and my team, Anisha and Bala. I'm going to present on the poster on the topic of multi-drug resistant tuberculosis. So, objectives of this session is how does this, what is MDR and how does this resistance occurs, and management, diagnosis and treatments. So MDR-TB is it is basically becomes resistant to powerful first-line drugs, rifampicin and isoniazid. So how does this occur? Normally, the RBO3 gene encodes beta subunit of RNA synthase. So this beta subunit of RNA synthase is required for the transcription and RNA synthesis. So rifampicin was blocking the RBO gene and it's blocks the transcription and RNA synthesis. And the CAT gene encodes catalase peroxidase, which activate isoniazid. The activated isoniazid inhibit INHA gene. So INHA gene is required for mycolic acid synthesis. So now the isoniazid is inhibiting the mycolic acid synthesis. Due to mutation in both the RBO gene and CAT gene, the resistant occurs in rifampicin and isoniazid respectively. When we see the statistics, so you can see that the India contributes 21% of multi-drug resistant tuberculosis in globally. According to WHO, 130,000 new cases are confirmed in India, and Risk factors which contributes multi-drug tuberculosis, drug-resistant tuberculosis. So people who do not complete a full course of drug-sensitive TB treatment and inadequately or poorly administered treatment, HIV positive patient with active TB, people who comes from already existing drug-resistant tuberculosis, and history of close contact with the resistant TB cases. How are we going to manage this MDR TB? So according to new guidelines 2019-2020, first foremost is the diagnosis. TB and TrueNAT detects the resistance of rifampicin, and we can use also line probe assay, which is used for detecting sensitivity for first-line and second-line drugs. For pediatric cases, we can use urine delirium, and AI-based chest X-ray can be used for early screening. And MDR TB treatment is newer treatment is PPAR regimen, which includes bedaquiline, predominate, and linezolid. And the patient should be advised to take full oral regimens, and they should be under the observation known as DOTS. Conclusion of this presentation is to combat multi-drug resistant tuberculosis in India, improving healthcare infrastructure, expanding diagnostic facilities, ensuring affordable treatments, and strengthening surveillance system are essential. The reference are taken from POC and Suryakanta and from WHO. Thank you.
Then continue the course or you have to restart the.
We can restart it from.
One month of any done. For money, we have not taken the exam. You can continue the course or you have to restart the list.
Price speaker. Bedaquiline works by inhibiting the ATP synthase enzyme. Predominate works by inhibiting the mycolic acid synthesis. Linezolid works by inhibiting the protein synthesis, and moxifloxacin works by inhibiting the DNA kinase. So these drugs should be taken with water and should not be taken with milk, milk-containing products or calcium supplements. BPAM regimen must be the first choice of treatment in eligible patients with multi-drug resistant or rifampicin resistant TB, regardless of their fluoroquine resistance status. So eligibility criteria for BPAM regimen are: the age must be more than 14 years, new microbiologically confirmed rifampicin resistant TB requiring a new course of treatment, person with exposure of less than 1 month intake of these drugs. If person with more than 1 month of exposure intake, there should be documented sensitivity to these drugs. Non-lactating, non-pregnant women, or if a pregnant woman less than 24 months ready to do MTP. People who had not failed treatment with midaflurin or lidazolam containing regimens. People with no significant conduction abnormalities, including structural heart diseases. People with no significant liver dysfunction. People with no severe form of extrapulmonary multi-drug resistant TB. The contraindications for the regimen are severe anemia, thrombocytopenia, leukopenia, significant hepatic dysfunction, severe renal failure, and severe neuropathy. Once the BPAM regimen is started, patient will be regularly monitored for BMI, CBC, visual acuity, smear microscopy, etc. Conclusion. BPAM regimen represents a significant advancement in MDR TB management, offering a shorter, more effective, well-tolerated alternative treatment for TB. Thank you. Yes, ma'am. No, they are. We have no complete reports on that less than 14 years.
Thank you. Next, we call upon Mr. Sania to present on the topic Pradhan Mantri TB Mukht Bharat Abhiyan.
A very good morning to everyone present here. I am Mirza Khania, and today I'll be presenting a poster on a crucial public health initiative, the Pradhan Mantri TB Mukht Bharat Abhiyan. Tuberculosis remains one of the most significant health challenges in India. It's not just a medical condition, but it's a social and economic issue affecting the most vulnerable populations. This initiative was launched in 2022 to eliminate TB by 2025, 5 years ahead of the global goal. The objectives of this initiative, there are three main objectives. Many patients struggle with access to healthcare, financial burdens, malnutrition, social stigma, making it harder for them to complete their treatment. Recognizing these challenges, the Pradhan Mantri TB Mukht Bharat Abhiyan was designed as a multi-sectoral approach to TB elimination. It brings together the government, private sector, and NGOs and the community to provide support to TB patients. The first objective is patient support, ensuring that TB patients receive the necessary assistance, including nutritional supplements, diagnostic support, and vocational rehabilitation to improve treatment. The next is community engagement, encouraging local NGOs, community organizations, and individuals to participate in TB control efforts by raising awareness and reducing stigma. The third is CSR, which stands for Corporate Social Responsibility, which involves private sector organizations in supporting TB patients through funding, healthcare initiatives, and awareness campaigns. Let's move on to the methodologies, how the program works. To achieve these goals, the initiative has implemented a structured framework which integrates multiple stakeholders. The first is Nikshay Mitra. Nikshay Mitra is an initiative where communities and NGOs and individuals can adopt TB patients and provide them with nutrition and financial support. And the next is needs assessment. The local authorities assess specific needs of TB patients in their regions. Based on this data, targeted interventions are made to ensure that resources reach the patients who need them the most. And the third is providing support. Because TB treatment can be a long and challenging process leading to malnutrition, economic hardships, nutritional support is provided as a food basket per month, which includes multiple food groups.
And the fourth is the Niksha portal. The Niksha portal is an innovative digital platform under the National TB Elimination Program for TB case management and surveillance. It facilitates patient registration, treatment tracking, and direct benefit transfers under the Niksha Poshan Yojana, providing 500 rupees per month for nutritional support. The portal integrates public and private healthcare providers, ensuring better TB case detection and reporting. In conclusion, the Pradhan Mantri TB Mukt Bharat Abhiyan is a landmark initiative in India's fight against tuberculosis. By bringing together the government, community, and corporate sector, we are not only treating TB, but we are creating a support system for those affected by it. It truly demonstrates the spirit of the slogan, TB harega, Desh jilega, meaning TB will lose and India will win. Thank you. Under Nikshan Mitra program, there's 500 rupees per month for TB patients. Okay. Thank you.
Thank you. Next, I would like to invite Krish to present on the topic NTEP. Good morning, everyone. My name is Krish, and I'm here to present the topic National Tuberculosis Elimination Program. My teammates are Kaushik, Krishnavedi, and Pratika. So let me just introduce what NTEP is basically. It's the flagship program by India to aim to eliminate tuberculosis by 2025. So basically, where did this vision come from? So the vision was put forward by WHO to create a world free of tuberculosis, such that zero deaths, disease, or suffering due to tuberculosis occur. The goal is to end global tuberculosis by 2035. So, and the UN also put forward its sustainable development goals to eliminate tuberculosis by 2030. But the Indian government has put forward an NTEP to eliminate it by 2025. So let's talk about the evolution of the TB elimination program in India. So in 1962, it was first put forward as the National Tuberculosis Control Program. And then in 1997, it was revised as the RNTCP, where the DOS strategy was introduced. The RNTCP in coverage was extended to the whole country in 2005. And in 2007, there was initiation of drug-resistant TB services. The visions of NTEP is basically to have a TB-free India with zero deaths, disease, poverty due to tuberculosis, and the goal is to achieve a rapid decline in TB burden, mobility, and mortality while working towards elimination of TB in India by 2025. Based on the National Strategic Plan, there are 4 steps, which is to detect, treat, prevent, and build. Detecting TB is done through active and passive case findings. Treatment is done through DOS and other regimens like BPAM. Prevention is done by vaccines like BCG vaccine and other the vaccines. Building is basically we have to build better health services to fight TB. Thank you. Eradication, it can't be eradicated because of the higher load of TB, ma'am, and it can also produce as a latent disease, which can have subclinical, we can have subclinical.
Next is our Sri Vashika, President of the topic, Public Health Action for the TB patient.
Good morning to one and all present here. I'm Sri Vashika and I'm here to present my topic, Public Health Action for TB Patients. So tuberculosis remains a worldwide public health problem, despite the fact that the first two organism was discovered more than 100 years ago, and there has been highly effective drugs and vaccine available, making it a preventable and curable disease. So the main reason why there has been an increase in TB deaths is due to reduced access to TB diagnostics and treatment. So what are the public health measures that we can undertake to control the disease? So first we have a contact tracing and investigation. We have passive case finding. Since the symptoms of the disease start developing early, we have to detect it so that the treatment can be initiated as soon as possible. And patients with comorbidities such as diabetes, HIV, smoking and alcohol use should be under close surveillance. TB patients should be identified under vulnerable populations such as in slums, prisons, and tribal areas due to poor sanitary conditions and easy contraction of disease due to close contact. So the diagnostic modalities that can help in case finding are sputum sphere microscopy. We have culture that is fluorescence dense medium. We have drug susceptibility testing, and we also have molecular tests such as CBNAT and lentiprobacid. Drug susceptibility testing has gained a lot of prominence recently due to emergence of drug-resistant strains. It helps in selection of effective drugs so that we know what the blood they are susceptible to. The supportive tools used chest X-ray. We have tuberculin skin test and interferon gamma assay. There has been a lot of government schemes and policy implementations undertaken. This helps in increasing public awareness for the disease. It helps reduce the incidence of TB and case-related mortality. So we have TB strategy, NTEP, National Tuberculosis Elimination Program, Nikshay Poshan Yojana. This aims to improve the nutritional status of TB patients by offering financial support. An amount of 500 is given every month so that their basic needs can be met. TB patients should be counseled properly since TB stigma is a prominent issue. This can lead to delayed treatment, there can be social isolation or a negative impact on mental health. So we should make sure there are awareness campaigns, any misconceptions of the disease should be avoided, and they should have access to quality TB services. They should understand the importance of drug adherence. They should know the disease, symptoms, transmission, and all the side effects that of the drugs we're going to prescribe. And finally, some important basic measures must be undertaken. A well-balanced, proper diet, a safe and hygienic environment with proper ventilation, vaccination, contact prophylaxis can all make a huge difference. A TB anywhere is TB everywhere. So let us all come together and help in elimination of TB. Thank you.
Thank you. Next, I would like to invite Shalini and her team to present on the topic TB health visitors.
Good morning, everyone. I'm Shalini. I'm here to explain the TB health visitors. So, firstly, what is TB? So, it is a pulmonary infection that affects mainly the lungs and also the other parts of the body. So, the most common disease prevailing in many countries. So, coming to the TB health visitors, TB health visitors are the first line health workers who play a crucial role in the management and control of the tuberculosis. So they mainly provide emotional support and psychological support to the patient. The main role of the healthcare visitors is to initiate the home visit and create awareness about the disease and initiate infection control practices, provide communication about the spread of the disease, and initiate the hygiene practices for the patients. how the home visit occurs. The health visitors first gets maximum information about the disease from the patient and their family members. Then the health visitors allot a particular time for the visit of the patient. And the patients are admitted to a research trials. So the trial occurs in this manner. Next, the method of detection, so the directly observed therapy, home visit and community outreach, screening, monitoring and evaluation. The other function is to create awareness to contain many TB elimination program to the patients. So, as the conclusion, we can make the TB control practice success by the combined effect of the healthcare workers and nurses. So mainly the healthcare visitors consist of 4 members, which can be a doctor, social care workers and nurses. So Chennai consists of 14 sectors totally. So each health visitor team is responsible for 1 sector. Thank you.
For reporting any TB patient and at the same perspective, doctors have a care with the Asha workers. They will also get these.
Okay. Thank you.
Thank you. Next, we welcome R. Sindhuja to present on the topic TB unit.
Good morning, respected dignitaries, faculty members, and one and all present here. I am R. Sindhuja. Today, I have the privilege of presenting on the tuberculosis unit, a crucial component of the National TB Elimination Program in India. The TB unit is a district-level supervisory unit responsible for diagnosis, treatment, and prevention of tuberculosis. It plays a pivotal role in implementing NTP strategies within its assigned geographical area. The TB unit has 2 key objectives. First, achieving at least an 85% cure rate for infectious TB cases through directly observed treatment short course with active involvement of peripheral health functionaries, and enhancing case reduction through quality sputum microscopy, aiming to identify at least 70% of estimated cases. The TB unit follows a structured workflow involving different population groups. Urban and rural populations are screened for TB symptoms. Then the suspected cases are referred to peripheral health institutions. Cases are then managed by the senior TB supervisor, TB health officer, and TB unit supervisor before being recorded under NTP guidelines for further action. The TB unit is a part of a well-organized hierarchy. Central TB division, it coordinates with national institutes and technical working groups. And then we have state TB cell, which includes state TB control societies. And then district TB center, which oversees TB units at a district level. And then we have tuberculosis unit, which directly manages TB detection and treatment. Then TB detection centers, which conduct sputum tests and screening. Private health centers, it provides community-based TB services. Population coverage, rural and urban population, that is 1 TB unit per 2 lakhs population. And then in hilly and tribal areas, 1 TB unit per 1 lakh population. The staffs at the TB unit are medical officer, he is responsible for TB control activities in the given area. And then we have senior treatment supervisors who provide supervision and support for treatment adherence and patient management. And then last, we have senior tuberculosis laboratory supervisor who oversees laboratory activities related to the TB diagnosis and monitoring. Key findings are shown in the data table. India bears the highest TB burden with over 2.64 million cases annually. The Stop TB Strategy 2006 and the National Strategic Plan 2017 to 2025 aims to reduce TB incidence and achieve elimination through early detection, drug adherence, and research. In conclusion, the TB unit is vital in early diagnosis, proper treatment, and community engagement, making TB a preventable and curable disease. However, challenges like drug resistance and sustained efforts require continuous action. With that, I conclude my presentation and I thank the Community Medicine Department for giving me this opportunity.
Thank you. Next, I would like to invite Kavi Nehru on to present the topic Nikshay Portion Yojana.
Good morning to one and all present here. And I'm Kavan. And my team members are Kirtana, Kirtika, Kiruba, and Kishan. And I'll be presenting on Nikshay Portion Yojana program. So till now, we've been looking at the treatment options management regarding TB, and I will be talking about one of the most specific programs that was introduced for tuberculosis. And it's a very important program and initiative taken by the Ministry of Health and Welfare, and it was introduced in April 1st, 2018. And initially, it was used to give financial aid or relief for TB patients diagnosed with TB. The amount was rupees 500 per month, but recently, on October 7, 2024, our Union Minister JP Nada had increased the amount to rupees 1,000 per month in order to boost the number of registrations under the portal and also to reduce the number of drop rates out of the program. And this program is very important because it provides financial relief. So this will encourage more people to take up more nutritious food, so they'll be able to afford more nutritious food. Thereby, they'll be able to build their immunity. So that way, they'll be having a fighting chance against the disease, and also it will help in reducing the mortality and morbidity rate of the disease, and also it will help in encouraging TB patients to actually to go through the full course of treatment rather than dropping out in the middle due to a lot of financial constraints in the past. And regarding eligibility, there is no specific criteria. The only criteria is that all TB patients who are registered under the National Tuberculosis Elimination Program are mostly eligible for this Nikshay Portion Yojana program. And this can be done by any healthcare worker or even the patient. They have to register on the portal and click patient, and under that they have to fill the demographic details like name, age, how they were diagnosed, which hospital they were diagnosed, and their bank details like their IFSC code, so that the money will be directly transferred to their bank accounts. So this will be transferred under direct beneficiary scheme, where the amount is directly transferred to the patient's bank account. And this program's main objective is to ensure that patients don't drop out of treatment of TB and they continue with their full course of treatment. And mainly also helps people from lower socioeconomic backgrounds so that they'll be able to afford the treatment. And regarding the reports, there have been more than 51 lakh cases, and out of which only 30% are receiving first amounts. So there are certain limitations to this program because once we given there are sometimes delay in the amount being transferred to the patient's bank due to a lot of administrative financial errors, and also there are certain cases where the patient misuses the amount and is not using it properly for their nutritional treatment or for their medication, where they use it for some other purpose, which destroys the complete impact of the treatment. And also there is also not a lot of awareness in rural areas regarding this program because they're not aware of this treatment. And there are certain limitations for this program because of this. So to move this program forward, there should be improved surveillance regarding this program, and we should be able to create more awareness in rural areas where they're not much aware of this program. And in conclusion, I'd like to see this is one of the most important schemes that has been introduced by our government so that it can help TB patients for its management and can help them giving financial relief so that they'll be able to continue their entire treatment without having to drop out in the middle. And it encourages more people to come forward. And also a doctor will be able to receive rupees 500 per TB case that's notified. And for each case that's treated, they'll be given an amount of rupees 1,000. And thank you. Yes, ma'am. They'll be given rupees 500, and if the patient's treated successfully, they'll be given 1,000 rupees. In Asha workers, around 250 rupees will be given. our ASHA workers for notifying a tuberculosis case to treat. For yes, ma'am. Yes, ma'am.
For each campaign, they will be taking part in the
Yes, ma'am. Thank you. Thank you.
Thank you. Now I call upon Naveen Raj to present on the topic Nikshay Mitra.
Good afternoon, everyone. This is Naveen Raj. My topic is Nikshay. So let us start with the Nikshay. How many of you know about Nikshay? Okay. So let us say we see a TB patient somewhere, and we observe that TB patient is suffering from not only disease but also emotionally and financially. So some of you will interest to help them, like providing any support. So it is good, and some of your colleagues sees this, and like 10-20 people also want to help any other patients, but they don't know how they can help and to whom they can help. Here comes the Nikshay Mitra. Through this portal, anyone from the community can help the TB patient. They can provide their supports if they want. So Nikshay Mitra is a community-driven initiative under Pradhan Mantri TB Mukt Bharat Abhiyan. So next thing comes to your mind is what is Nikshay Mitra and what we can do to the patient. The person who is helping the TB patient, he himself is the Nikshay Mitra. Nikshay Mitra essentially means the donors, and we can provide any type of supports, including medical support, nutritional support, and vocational support. Medical supports like providing essential diagnostic methods for them, providing drugs for them, or providing essential medical care for them. Nutritional support include we can provide proper foods for them if they can't afford. Even you can provide emotional and psychological support to the TB patient to overcome the disease. We have Nikshay Mitra, this type of support system for the TB alone, but not for all diseases. It is because of two reasons. One is India have the highest TB burden globally. Second reason is if we are able to improve the quality of life of the patient, patient will be better able to fight against the disease. So we can become Nikshay Mitra by going to this website and we can register ourselves. I want to conclude by saying let's end TB together. Happy New Thank you. It was started in September 9, 2022. Thank you.
Thank you. Next, I would like to invite Pradiksha and her team to present on the topic TB burden.
Good afternoon to everyone. I am Pratiksha and my team members are Pratik, Prasanna, Prarthana and Pradeep. My team and I have prepared this poster on the topic
the burden of tuberculosis, and I am here to talk about the factors, prevalence, consequences, and impact of TB, and the key measures that can be taken to prevent it. And the objective of this presentation is to raise awareness about the global and local impact of TB and to educate the public on its prevention, symptoms, and treatment, and to increase the efforts to combat the disease. First, let's talk about what TB burden is. The term TB burden means the global and local impact of TB, including the new and existing cases, mortality, and economic consequences. There are few factors that I would like to highlight upon which make TB so widespread and deadly. First, HIV co-infection. People with HIV are much more vulnerable to TB infection as it weakens the immune system. And poor living conditions like poverty and overcrowding can also make TB spread faster. And malnutrition and smoking can also add the probability of occurring the disease. Then there's the issue of drug resistance, which is harder and expensive to treat, which makes controlling the disease much more difficult. And the social stigma of TB prevents many patients from seeking timely medical help, which further worsens the spread of the disease. When we look at the global survey, TB is one of the top 10 causes of death globally. And in 2024, approximately 10.8 million people were being diagnosed with TB, marking the highest number of records. And this represents an increase from 10.4 million cases in 2021 and 10.7 million cases in 2022. Even TB-related deaths decreased marginally from 4.6 million cases in 2021 to 1.25 million cases in 2024. TB has overtaken COVID-19 as the leading cause of the infectious disease-related death. Coming to the prevalence rate, the World Health Organization has started TB global monitoring in 1995. And even though TB affects every region of the world, the burden is disproportionately higher in certain areas. Southeast Asia, Africa, and the Western Pacific regions account for the majority of cases, with India, Indonesia, Bangladesh, Pakistan contributing more than 50% of the cases. And India has the highest number of TB cases with a prevalence rate of 26%. And while other countries like Indonesia and China also face significant burden with the prevalence rate of 10% and 6.8%. And the prevalence rate of Pakistan is 6.3% and Bangladesh is 3.5%. Now moving on to the impact and consequences of TB. Beyond the health impact, TB also has serious social and economic consequences. It causes low productivity, high treatment costs, and economic burden, mainly in countries with lower income, but the resources are already limited. And TB treatment can last for at least 6 months, and for multi-drug resistant TB, it can take up to 2 years, leading to prolonged loss, absence from the job, and many TB patients lost their job due to the social stigma as the employees fear transmission. And even after recovery, many TB patients are struggling to find employment due to the stigma, and this leads to social discrimination and worsening their mental and emotional health. Now let us talk about key measures that can be taken to eliminate TB. There are a lot of work being done by WHO to address TB, and World Health Organization NTB strategy aims to reduce TB death by 90% and TB cases by 80% by 2030. And advanced diagnostic tools such as gene expert and AI-based detection are being carried out to enable early detection and diagnosis. Then introduction of shorter regimens such as BPAS for multi-drug resistant TB are prescribed to ensure effective treatment. And vaccines like BCG vaccine can help to prevent severe form of TB in children. Then, but we not only need just treatment, so public awareness and educational campaigns are being held to make sure people know about TB symptoms and to know when to seek the medical help. And coming to the conclusion, TB continues to be a huge global health problem, but by understanding TB better and working together, we can reduce its burden on our world. Thank you. Uh, 10.8 million cases. India,
What is the definition of incidence? What's the definition of prevalence?
Incidence is the currently TB cases. Incident means current TB cases, and prevalence is overall rate of TB cases.
and seeing children, what is the prevalence of the body of the
The rate of cases in certain areas.
The rate of TB cases in a particular area.
Thank you. Now, I call upon Shobika E. to present on the topic TB preventive treatment.
Good afternoon to one and all present here. We are here to present about TPT. We know that TB can be prevented and cured. Now let's take a look at the crucial step in our fight against TB, which is TPT. Do you know what is TPT? TPT is a course of one or more anti-tubercular medication given to patients who have latent tubercular infection to prevent them from developing active TB disease. Do you know what is latent TB infection? Latent TB infection means the person who is infected with the TB bacteria but who don't have these symptoms. Do you know why is it important? It is to prevent the latent TB patients to develop from the active TB patients, and it is also used to prevent immunocompromised patients who are at high risk of developing TB infection. Do you know who should receive TPT? Maybe one close contact with TB patients and healthcare workers, and who have weak immune systems like HIV patients. And now let's see the treatment options. We have two treatment options, shorter regimen and longer regimen. In shorter regimen, we have 12-week regimen, which includes rifampicin, isoniazid, which is administered weekly once. And then we have 3-month regimen, which includes rifampicin and isoniazid daily for 3 months. The first two regimens are suitable for all the age groups. And then 1-month regimen, rifampicin and isoniazid is administered daily for a month. It is recommended only for adults and adolescents. And then we have a longer regimen, which is a 6-month regimen and a 9-month regimen. In 6-month regimen, we administer isoniazid daily for 6 months, and it is the most preferred one. In 9-month regimen, we administer isoniazid daily for 9 months. It is effective, but it is not preferred due to the duration.
Do you know what are the crucial steps in TPT?
In TPT, the following steps are followed. Identification of the population at risk, and then screening is done for the selected population at risk, and then we have to exclude the active TB, and then we have to initiate the TPT and then complete the TPT.
How is it monitored and evaluated?
Under the National TB Elimination Program, monitoring TPT includes management of the missed doses and the areas. Early detection and adherence to the prescribed regimen is the key to success. I would like to end the presentation with a quote by Benjamin Franklin: "An ounce prevention is worth a pound of cure." Thank you.
Who are in close contact with the TB patients and immunocompromised patients.
What the criteria for outdoor contact? Suppose one at I think the criteria, you can take no negative exposed isolation. We are concentrating exposed to TB patients. We are not what's the criteria of household contacts? Definition of household contacts.
2 days or 1 week.
So they should have exposed in this case, that is being positive. Should have shared 1 or more nights. 1 or more nights that in this case. Within 3 months before starting the baby treatment of the infections. And for inconsiderate patients, we will start taking the therapy. So we can see we have to test for PSD, right? Infection. We have to admit as per the patient. possible some without even that we can do or one medication. In case of immunocompromised patients. Thank you.
Thank you. The last participant will be Varshita Reddy and her team to present on the topic NTB strategy.
Good afternoon, everyone. My name is Varshita, and today I'm going to present about the NTB strategy. So, before talking about the NTB strategy, the DOT strategy was introduced in the year 1994, and it was continued till 2005 when the Stop TB strategy was introduced. And the Stop TB strategies were continued till 2015 when the NTB strategy was introduced. The main vision of the NTB strategy is to create a world free of tuberculosis with zero deaths, diseases, and suffering due to tuberculosis. And the main goal is to end the global tuberculosis epidemic. Now, the milestones which were reached by 2020 is there was a 35% reduction in TB deaths, and by the year 2025, there was a 75% reduction in the TB deaths. The main target goals was to reach a 90% reduction in the TB deaths by the year 2030 and a 95% reduction in TB deaths by the year 2035. Now, when you see in the TB incidence rate, there was a 20% reduction by the year 2020, and there was seen a 50% reduction by the year 2025. And the target goals for the reduction in TB incidence rate by 2030 was to reduce it by 80%, and by 2035 it was to be reduced by 90%. And there were zero families who were affected. There were zero TB affected families who are facing catastrophic costs. There are four main principles involved in it. The first is government stewardship and accountability with monitoring and evaluation. The second is strong coalition with civil society organizations and communities. The third is protection and promotion of human rights, ethics, and equity. The fourth is adaptation of these targets and strategies at country level with global collaboration. There are three main pillars. The first is integrated patient-centered care and prevention, which revolves around the early diagnosis of TB and providing them with affordable treatment services. The second is bold policies and supportive systems, which revolves around the political commitments, various health policies, and more. The last one is the intensified research and innovation, which revolves around the production of the new tools and promotion of new innovations. Now, the global plan targets can be introduced as 90, 90, and 90. The 90% of all people with TB are to be placed on appropriate therapy like first line therapy, second line therapy, and preventive therapy as required. And we also want to target the 90% of the key population who are at high risk and are more vulnerable to acquiring TB infections. And we also want to see a 90% treatment success rate by providing affordable treatment services. Now, as every strategy, this NTB strategy also has barriers to it. There are four main barriers involved. The first is weak healthcare system. The second are underlying determinants of TB, such as poverty, undernutrition, migration, aging populations, and risk factors such as diabetes, silicosis, and smoking. The third is lack of effective tools, and the fourth is continuous unmet funding needs. Thank you. HIV. Silicosis.
Thank you all the participants and the judges. A huge congratulations to one and all participated today, and your timeless efforts mattered, and I hope everyone enjoyed this session. We'll sit back and wait for the results.
I'm not here. First virtually. Yeah, the first one you can announce also. Ready on. Switch off on sound. I'm repeating the learning switch off on 11. Check my number.
Meanwhile, our next session will be each faculty paper presentation. Our first participant will be Dr. Hidayatullah sir.
Wait. As per schedule, इधर आगे थे. First last one. Time for meeting. 8:30 minutes. Okay. Vijay Karthikeyan. As Vijay Karthikeyan is ready. Which number?
18.
Mic shoot பண்ணிக்கலாம். Vijay Karthikeyan ready கேளுங்க. Okay. Mic shoot பண்ணிக்கலாம். கேளுங்க பேசணும்.
Hello sir. Vijay Karthikeyan sir. Can you hear us?
Yes, ma'am. Yes, yes.
Yes, sir. Are you ready to present the papers?
Yeah, ma'am. I can present.
Screen sir. As in please.
I can share the screens.
Is there? Okay. Yeah, no problem. We will share.
We'll share. Mute.
Next slide.
Check.
It'll take 3 minutes. Time 5 minutes. 7 minutes. Also time. Mute பண்ணுங்க. Slide.
We now kindly request our judges to occupy the stage to give the results.
Review.
Please go to the next slide. I'm going to take this.
And we can see from here.
Okay.
Shall I start, sir?
Yeah.
Oh. So, good afternoon to one and all present here. Myself, Dr. M. Vijay Karthikeyan. I'm an associate professor from the Department of Community Medicine from Vinayagam.
Sir, can you hear us?
Yeah, ma'am.
Sir, start in another 2 minutes, sir.
Yes, ma'am.
Yes, sir. So our next session will be PG faculty paper presentation. For that, I would like to welcome our beloved judges, Dr. Satish Kumar sir, Department of Pulmonary Medicine, and Dr. Prabhakaran sir, Department of Community Medicine. Our first participant is Dr. Vijay Karthikeyan sir on the topic prevalence of epidemiological profile of pulmonary TB among elderly population residing in the old age homes in Salem. Over to the session. Sir, you can hear us?
Yeah.
Yes, sir. The time is for 6 minutes, sir. And then followed by the question and answer session.
Sure. Good afternoon to one and all. Myself, Dr. M. Vijay Karthikeyan. I'm associate professor in the Department of Community Medicine from Vinayagam Medical College. I'm here to present my original research article titled Prevalence and Epidemiological Profile of Pulmonary Tuberculosis Among Elderly Population Residing in Old Age Homes in Salem District, Tamil Nadu. Next slide, please. Next slide, please. Can I have the next slide? So globally, if you take nearly 11.6 is the prevalence of tuberculosis as per the WHO report 2022. And also, if you take nearly 1.3 million deaths has been reported in 2022. And if you take the majority of the burden of the tuberculosis is backed by the Southeast Asian regions with nearly half of the burden. And the elderly population is considered as one of the neglected groups. They are often missed during the routine screening practices, and either they are missed or they are misdiagnosed. And mortality rates also, if you take it, is very much higher among the elderly population. Nearly it is 6 times higher when compared to the general population. And those among who the age is more than 70 years, if you take, the mortality is nearly 30%. And there is a very good substantiating evidence to the fact that the global tuberculosis burden can be put to an end only if we can screen and bring in more cases in the high risk and the key population, and old age people are one of the important key population. Next. With this following objective, I have with this available background, I have planned my study with the following objective. Next slide, please. So my primary objective is to estimate the prevalence of pulmonary tuberculosis among the elderly population in the old age home. Second objective is to assess the epidemiological profile among the elderly population with tuberculosis and to determine the various factors associated with pulmonary tuberculosis among the elderly population. Next slide. So with this objectives, my study is an analytical cross-section study which was conducted in selected 10 old age homes in Salem district. All the old age homes were listed, and from that using simple random sampling, 10 old age homes were selected. And those who are more than 60 and above years of age and who gave consent was taken into the study. The sample size was calculated based upon a previous study done by Nehal et al., taking the prevalence of pulmonary tuberculosis to be 18.71% among the elderly population. The sample size was rounded up to 300. And these samples were chosen using simple random sampling method using computer generated random numbers. And the data collection was performed using a pre-tested semi-structured questionnaire, and the study was carried out for the period of 1 year. And those who have severe debilitating illness and who are psychiatric patients, they were excluded from the study, and the informed consent as well as the IEC clearance was obtained prior to data collection. And the study was funded by Tuberculosis Association of India with a funding of 40,000. Next slide. So as you can see that the table 1 depicts the socio-demographic characteristics. The majority of the study participants, that is nearly 60%, were females and 50% belonging to 60 to 70 years of age, and majority had an education above up to high school, that is 60%. Next slide. So this and if you take the prevalence of pulmonary tuberculosis from figure 2, you could see that nearly 2.6 is the prevalence. That is, out of those 300 participants, 8 of them had tuberculosis. Among these, if you take 2 of them were already known case of tuberculosis, 6 of them were newly diagnosed in our study. Next slide. So the figure 2 depicts the various presumptive symptoms that we can see among the study participants. Among 300 study participants, 71 of them had any form of presumptive symptoms, and among that, cough was the most important presumptive symptom, which was widely prevalent among nearly 15.6% of the study participants, followed by fever for 11%, and hemoptysis and weight loss also present in some of the study participants. Next slide. So on assessing the living conditions of the old age homes, we could see that nearly 60%, that is 62%, were staying in a dormitory type of room, and also the ventilation was inadequate nearly in 72% of the individuals in the old age home, and also inadequate lighting was present nearly in 2/3 of the old age home rooms. And this is what the schema of my present this study. We screened nearly 300 individuals for presumptive symptoms of tuberculosis. Among them, 71 was diagnosed with had any form of presumptive symptoms. All these 71 individuals underwent 2 types of diagnostic modalities. One is AA-based X-ray screening was done, as well as sputum samples were collected for AFP staining, and nearly 21 of the study participants had abnormal X-ray finding, and as I told, 8 of them had tuberculosis. Among these, 2 were old case and 6 were newly diagnosed. Next slide. So moving on to the various factors that are associated with the tuberculosis, we could find that presence of any of the presumptive symptoms, and also those staying in inadequately ventilated rooms, and those with any form of comorbidities were found to have more prevalence, and it was found to be statistically significant. And I have just depicted the variables which are statistically significant only in this table. Next slide. I have used the features test with the Yards correction for this analysis. Next. So our study finding was found to be corroborating with the previously available data. And also we could say that similar studies done by Zhang et al., Nanjing et al., and Zhang et al. Were is similar to our study findings. But one important peculiar thing that we did is that we also assessed the living conditions of the old age homes that was missing in many of the studies. Next slide. So to conclude, the prevalence of tuberculosis was 2.6% in this study, and also it was higher among the old age inmates. And the results indicate that the key population should be concentrated for routine screening. So nowadays we are not doing routine screening for elderly population, that too in old age homes. So that has to be concentrated, and also there has to be routine screening in our country level in the programmatic change itself, in order to make sure that the TB is being eliminated. So next slide. So I would recommend that proactive intervention has to be put forth, and also the diagnosis in the elderly population has to be done at the earlier stage, so that they could be put on any form of treatment. And also we have to make sure that the old age homes, the condition of the old age homes has to be improved appropriately, and also any comorbidities has to be properly managed. Okay, so the disease and they have to be adequate for that the control can be reached and the disease burden can be reduced. So this, I would like to conclude. And also, we have the opportunity screening. Those who have any comorbidities, they have to be bidirectional screening has to be implemented. So next slide. So these are the various references that I have used in my study. Thank you all for the opportunity.
Over to the judge.
Yes, sir.
Yeah, because very study. So, I have two questions from my end. What is from methodology? Said 10 old age home are selected. So, what are the methodology we use over there? That is one. So, we have to the X-ray to screen all procedure X-ray, how X-rays coming back.
So what I did is that first I got the list of all the registered old age homes in Salem district. So I used that as my sampling frame and I chose the 10 old age homes first in the first phase. Next, what I did is that the old age home, 30 samples were chosen and they were screened. So that for one old age home, 30, so 10 old age homes, 300 samples was taken, and all these 30 in each of the old age homes, they were screened for any of the presumptive symptoms. And those who had presumptive symptoms, they were put on the X-ray modality for diagnosis, as well as we did the sputum smear in those individuals who had any of the presumptive symptoms. That is what we did.
So, how you are this time in old age home? Like each old age home, how many samples you segregated, and how many X-rays were conducted?
Yes, each old age home I samples. So in preliminary the baseline itself, we got permission from all the old age homes and willingness, we enrolled them into the study, as well as we got the approval from the district social department and also the as well as the state level tuberculosis officer permission was also obtained here. So each old age home we took 30 samples. That was determined based upon our sample size. So 30 old age home. So they were chosen using simple random sampling method. If there are 60, we just generated the random number table and we just chose those 30 in the from each of the old age homes.
Used to mobile X-ray screen or portable X-ray videos?
Sorry, sir?
Which modality the X-rays were conducted? Mobile labs or portable X-ray suites? How was that?
How was the X-rays conducted?
Yes, sir. X-ray, what we did is that we got the DD tuberculosis permission of Salem district. So the mobile-based X-ray, that is AI-based mobile van, they sent for each of the old age homes. So those who had presumptive symptoms were screened with this AI-based X-ray, as well as samples were collected by the FCS from the district. So through the district tuberculosis center, we just collected with their help. Mobile-based X-ray only was done.
Thank you. Good morning, sir. Harish Kumar, sir, project professor, Spirit Medicine. Just today, 8 people were diagnosed with tuberculosis. All were here positive or against positive or only X-rays.
8 of them had this. They were positive for sputum. TB-NAT was done for them. They were positive for AFB.
TB-NAT, not TB-NAT positive.
Yes, sorry, TB-NAT positive.
Okay, sir. Abnormal X-rays diagnosed only by AA or any clinicians also related.
So 21 of them had any abnormal finding in the AA-based X-ray, but we find that only 8 of them had the TB-NAT positivity also.
Okay, sir. Yes, sir. Please study the
Thank you, sir. Next, I would like to invite Dr. Radha ma'am to present on the topic.
Yes.
Are we on?
Okay, I'm checked off.
ಕಳ್ದಿಟ್ಟಿಲ್ಲ ಕಳ್ತಿರಿ ಮೋಸ್ಟ್ ಕಳ್ತಿರಿ
But I didn't able to see the screen, sir. Can you share the screen?
1 minute. Now you can press it now.
So should I present, sir?
Yes, ma'am, you can press.
Yes, sir. Thank you, sir. Good afternoon, everyone. This is Dr. Vishnu Priya from Government Trivandrum Medical College, third year postgraduate. I'm here to present a poster regarding tuberculosis meningitis, which is a silent threat. At the end of this poster, we will be able to know why it is called a silent threat. So, introduction. CNS TB, it is a life-threatening manifestation, as we all know, which is primarily caused by Mycobacterium tuberculosis. It predominantly affects the meninges, which result in inflammation, and it is causing significant neurological complications. If it involves the brainstem, it will be commonly associated with cranial nerve palsy, especially 3, 6, and 7. It is important to diagnose early, and timely initiation of treatment is mandatory, as delayed management can lead to severe and irreversible neurological damage. So I'm here to present a case of TB meningitis. Name of the child is Adi Seshan, 11-year-old male child. He presented with the history of fever for past 10 days, history of headache, history of altered sensorium was there, history of neck pain was there, history of inappropriate speech for past 2 days was there. On presentation, there was a meningeal sign was present, that is Kernick and Brudzinski sign was positive, and there is focal deficit in the form of weakness in both the lower limb. So the child was admitted and evaluated in view of acute CNS infection. So the investigation done, the routine investigation was done. It shows a CBCs. There is a total count elevated with lymphocyte predominant, and CRP is positive. ESR is also elevated, but we won't be able to find any primary focus in the chest, where the chest radiography was normal. So lumbar puncture was done with the CSF analysis done on day 1 of hospital admission before starting antibiotic, followed by lumbar puncture. We have started intravenous antibiotic empirical, which is zone, acyclovir, and vancomycin in a meningitic dose. The CSF analysis revealed a count of 200 cells, which is the lymphocyte predominant is there, and glucose was found to be low, and elevated protein was there. We have sent CPNAT. It was positive for Mycobacterium tuberculosis. Fundus examination we have done. It was found to be normal, and CT brain imaging. It was normal. So we have suspected TB meningitis in view of CSF count and clinical picture.
we have consulted a pulmonologist. They have started ATT on day 2 of hospital admission, but the child deteriorate on day 2 in the form of poor GCS. So the child necessitated intubation and ventilator support. The child was continued ATT and corticosteroid following the diagnosis. Then further neurological examination revealed that he had a diminished tone and reflexes in all 4 limbs. And further, it is evolved to areflexia, which is absent reflexes was noted. Child was deteriorating in spite of ATT and corticosteroids. The child was continued ventilatory support, and in view of prolonged ventilatory support, the child was done tracheostomy and continued ATT. Why it is a silent threat is if the child initially he was presented at stage 3, despite ATT despite ATT we have started the disease prognosed, and it leads to sequelae, which is hydrocephalus. He developed hydrocephalus after 1 month of diagnosis, which required a VP shunt. So this is the image of the child where there is a hydrocephalus followed by VP shunt was done. Unfortunately, the child developed permanent neurological sequelae. That is, the child developed quadriplegia, and he had intellectual disability. My conclusion is this case actually it underscores the severe outcome which is associated with TB meningitis. So it highlights the importance of prompt clinical recognition and rapid diagnostic technique and early therapeutic intervention to improve the patient outcome. In this case, despite aggressive management, the prognosis is guarded, particularly if he is presented in 3rd stage, which leads to permanent neurological sequelae. So the scope of improvement, I would suggest that further research is essential to develop more rapid diagnostic method, and we have to optimize treatment strategy for TB meningitis. Enhanced early detection protocol and innovative therapy approach may significantly improve the patient outcome, and it actually reduces the long-term sequelae. Like in this case, this child developed a quadriplegia and he is bedridden for the entire life. This is the case. This is the case regarding. This is my poster regarding this case. TB meningitis, a silent threat. Thank you.
Yes, sir. Yeah. Am I audible, madam?
Yes, sir.
Satish Kumar, I'm the secretary substitute professor. Will you see for any contacts this patient, any family members or neighboring relatives or or exposed to tuberculosis? Any contacts you send?
Is there any contact screening you have done, madam?
Yes, sir. We have done contact screening of parents, but we couldn't able to find the contact, sir. There was no primary focus also, sir. We couldn't able to find out that, sir.
Have you done ADL test, madam, from CSF?
Sorry, sir.
ADL test from CSF done?
No, sir. Actually, in our college, that is not available, sir. Hence, we didn't done, sir.
CSF CBN is positive.
So, CBNAT test positive, no, from your CSF
Yes, sir. Yes, sir. CP-net was found to be positive, sir.
How long the steroids were continued for the patient?
Ma'am, we have continued for 6 weeks, ma'am. As per protocol, as per Nelson guidelines, we have continued for 6 weeks. Despite steroids and ATT, there was no improvement in patient condition, ma'am.
Thank you. Thank you, ma'am.
Thank
Next,
you.
The next presenter is Dr. Kirti Narayanan, ma'am, on the topic lateral rectal palsy of masquerader of TB meningitis, a case report. Ma'am, can you hear us? Sir, can you hear us, sir?
Am I audible, ma'am?
Yes, sir, audible. Can you hear us, sir?
Yes, I can hear you, ma'am.
Yes.
May I start presenting, ma'am?
Screen is
Sir, is the screen visible for you?
Yes, madam. Yes, madam. It's visible.
Yes, sir. The presenting time is for 5 minutes, sir, followed by the question session.
Okay, madam. Okay, madam.
Sir, you can start now.
Okay, madam. Good morning, everyone. I'm Dr. V. Kirti Narayan from Government Tagore Medical College, working in Department of Pediatrics as second year postgraduate. I'm presenting this e-poster on a topic of TB meningitis. The child initially presented with very atypical signs and symptoms. To dwell on to this topic, I will start presenting now, ma'am. Tuberculosis meningitis is the most severe form of extrapulmonary tuberculosis and can present with a wide range of neurological symptoms. While cranial involvement is not very uncommon, isolated lateral rectus palsy is an initial presentation in this case. And why have I chosen this case to present as a e-poster? Because this child present to us only with the complaints of fever. Sorry, ma'am.
Yes, sir, you're on.
Yes, sir. Why this case? Early recognition and initiation of anti-tuberculosis therapy are critical in reducing the risk of severe neurological sequelae. This case report underscores the importance of maintaining high index of suspicion for tuberculosis meningitis in patients presenting with atypical clinical features, such as in this patient, especially in endemic areas like in our India. It also highlights the need for a comprehensive diagnostic evaluation every time we are suspecting tuberculosis. My patient initially, her name is Jayashree. She was 8 years old. She presented with only non-specific complaints like headache, fever, and irritability. Initially, there was no index of suspicion for tuberculosis. The child initially had, in our lab findings, she had anemia, leukocytes, elevated total count with thrombocytopenia. Elevated WBC count was around 15,600. The polymorphs were elevated, and platelet count was around 1.27,000. The RFT, LFT, and other parameters, serum electrolytes were normal. Peripheral smear was done and showed microcytic hyperchromic anemia with no other significant features. The inflammatory markers were elevated. CRP positivity showing around 48 milligram per deciliter of quantity, and elevated ESR like for the first half an hour, and 68 mm per hour was for the next 1 hour finding. Blood culture showed no growth, and urine protein and culture were normal. The child initially presented with only these non-specific symptoms. Only upon examination, we came to find out that she had an intermittent lateral rectus palsy manifesting with the diplopia. She didn't complain this to her parents as well. Only on examination, it became apparent, and all other CNS examination was normal. The child was able to maintain saturation in room air. She was having optimal perfusion. She was just showing irritable signs, fever and headache. Her fever was almost having a high-grade fever pattern around 101 to 103 degree Fahrenheit. And initially, we had suspicions for acute disseminated encephalomyelitis like ADAM and other, even a possibility of other autoimmune disease, and also some tropical infections. but we didn't think of TB as the first choice of diagnosis at that point. We suspected for a mass in the brain, so we did a CT brain initially, madam, and it came out to be negative. To cover our path right, we started on empirical antibiotics like vancomycin, meropenem, and ceftriaxone and acyclovir. Our initial CSF analysis showed decreased glucose, but it was not very significant to suggest or not pointing us in the direction of tuberculosis. Her CT brain was initially normal. On day 3 of hospitalization, the child started deteriorating with signs of raised intracranial tension. She showed hypertension. She had a decreased heart rate. So we started her on anti-edema measures. 3% saline was started as a loading dose of 5 ml per kg, followed by a continuous infusion of 1 ml per kg per hour with injection dexamethasone, 4 mg IV TDS. A repeat CT brain was done for her the same day, and she revealed features of hydrocephalus. Her CT imaging was displayed in the poster, ma'am. Then we did a magnetic resonance imaging the next day following this, while on anti-edema measures with antibiotic coverage, which revealed same the hydrocephalus was confirmed again with basal meningeal involvement. We consulted our neurosurgeon, and he said that the child is in need of emergency ventricular peritoneal shunting, and it was done the following day, ma'am. The initial LP reports didn't suggest as much to point towards the direction of tubercular meningitis, but later on, intraoperatively, CSF samples were obtained, and those samples were sent for analysis. It showed decreased glucose, elevated protein levels, and the CSF CpNat from that sample also confirmed Mycobacterium tuberculosis. She was and then promptly stopped her on anti-tuberculosis therapy with a weight band of 20 kg. We started on her on 4C and 4E regimen, ma'am. Then over the course of treatment, her symptoms gradually started improving, and she's on regular complaints, and she came back for follow-up also. Recently, she got admitted last week with a displacement of ventricular peritoneal shunting, so she was referred to Tagore Medical College for further surgery, and now she's doing well, ma'am.
Can you conclude, please?
Sir, I cannot hear you, sir.
Can you conclude, please?
Yes, sir. Thus, the outcome of TBM depends on the stage at which ATT is initiated. This child presented initially on stage 1, later progressed to stage 2. The presence of recent onset lateral palsy in patients with low-grade fever, headache, and alteration in mental status and meningitis is important, although not a pathognomic sign for diagnosing tubercular meningitis. My references are Nelson textbook of pediatrics and some journals regarding lateral rectus palsy patients with TB meningitis. Sir. Thank you, sir.
Thank you, sir. Over to the judges.
It's a very good case actually. And what sample got senior questions, sir?
Sir, sorry, sir. It's not clear.
So, in what sample did the CT become positive?
CSF, sir. Initially, we did a lumbar puncture and we did CSF analysis, but it didn't turn out to be CSF positivity for tuberculosis. Whereas intraoperatively, while doing ventricular peritoneal shunting, it came out positive, sir.
What is the prevalence of this lateral rectus palsy in presenting as tuberculosis meningitis presenting with lateral rectus palsy? Have you gone through any case reports or something?
Yes, ma'am. Typically for lateral rectus palsy, I don't know the percentage of presentation, but cranial palsies can occur in about 25 to 30% of TB meningitis cases, ma'am.
Any case reports are there specifically for this lateral rectus palsy?
Adult case reports are there, ma'am, but pediatric cases not so much, madam.
Okay. Thank you.
Thank you, madam.
Thank you, sir. Thank you, judges.
Thank you, sir.
Next, I would like to invite Dr. I.V. Groshki to present on the topic Management of NDR TB.
On this one only.
Good afternoon to everyone. I am Dr. Eileen, Hemsert, New Delhi. I'm a postgraduate first year student in pharmacology department. So the topic that I'm going to be talking about is management of MDR-TB, a clinical perspective evolution. So India has the highest burden of MDR-TB, ranking first globally in both new and previously treated TB cases. So my objective is to analyze the factors contributing to MDR-TB, evaluate the challenges in management, and explore potential solutions. So when it comes to clinical assessment, it is caused by Mycobacterium tuberculosis. Signs and symptoms, so the patient usually presents with persistent cough for more than 2 weeks, weight loss, loss of appetite. In certain cases, there might be hemoptysis. And when it comes to risk factors, the patient, so the elderly people, people with diabetes, HIV, people on immunosuppressant drugs, all these people can easily get MDR-TB. So for diagnosis, we can diagnose by site TB. Then there's Lyme probe assay, which is genotypic drug susceptibility test. And then there's CB-NAT for MDR-TB, through which we can detect the resistance for isoniazid, fluoroquinolone, second line drugs, and ethionamide. Then there's urine lamp to detect TB in cases of advanced HIV. And then there's AI-based chest X-ray, which is used for screening and triaging. For TB prevention, we should have a healthy diet, which is protein-rich and fiber-rich diet, wearing masks, maintaining distance from infected cases, and maintaining personal hygiene, and getting BCG vaccination at birth. So the treatment for MDR-TB, according to the update of NTEP in August 2024, is BPAM regimen, which is a 6-month regimen, all oral tablets. So the criteria for this BPAM regimen, it must be monitored under DOTS. So linezolid is usually given 600 mg for 6 months, but in cases of severe toxicity, treatment interruptions for more than 2 weeks, the dose is decreased to 300 mg and the period is extended to 9 months. So for eligibility, age criteria is more than or equal to 14 years, microbiologically positive test for MDR-TB, less than 1 month prior exposure to bedaquiline, pretomanid, linezolid, no severe complications such as CNS TB or miliary TB, cardiac arrhythmia, or liver failure. The QT waves in ECG should be less than 450 millimeter per second in males and less than or equal to 470 millimeter per second in females. So why BPAM is gaining attention? That's because linezolid tapering is usually done to prevent toxicity, and the number of drugs is reduced compared to the older regimen. So there are digital and AI innovation. So when it comes to digital and AI, there is Nikshay portal through which the doctor can notify the case that he finds, and the doctor gets paid 500 rupees for notifying, and on completion of treatment he'll get another 500. This is applicable for all healthcare workers who provide details about the notified cases. Then there's AI in X-ray interpretation, CAD tools, which is used to detect TB in the early stages. Then there's digital technologies such as 99 dots and every med, in which patients use their mobile phones to update online about their daily drug usage. And then there's mobile apps like Arogya Sati. Then research and evidence are done by TB Practil, Zenix, MBPAL, ICMR. So the 6-month regimen BPAM, which consists of bedaquiline, pretomanid, linezolid, and moxifloxacin. So in this, the linezolid dosage is usually 600 mg for 26 weeks. But if linezolid toxicity is noted, this 600 mg is reduced to 300 mg. And its effectiveness is 88 to 91% according to studies done by TB Practil and WHO. In this BPAM regimen, peripheral neuropathy accounts 24% and anemia 10 to 15%. So there is this new regimen modified BPAL, which is still under clinical trial by ICMR and NIRT, which consists of bedaquiline, protomanid, and linezolid. So in this, the linezolid is given in 3 different doses. So in arm 1, it's 600 mg for 26 weeks. So when it comes to arm 2, it's 600 mg for 9 weeks, and then it is reduced to 300 mg for 17 weeks. And in arm 3, 600 mg for 13 weeks, and then followed by 300 mg for 13 weeks. The advantage of this is reduced linezolid toxicity, and the effectiveness in this trial was 93 to 94% based on ICMR and NIRT research. So in arm 2 and arm 3, peripheral neuropathy is just 2% and severe anemia is 4 to 6%. Since linezolid tapering is done, this treatment course varies from 6 to 9 months. So there's a National Tuberculosis Elimination Program in India. Their goal was to eliminate TB by 2025, 5 years ahead of United Nations goal. So in that, the key components are universal drug susceptibility test, diagnosis of verified notified TB patient, then NICSHAPE portal, the doctors to notify about the patients, then private sector engagement to provide incentives, notification, and treatment. Then there's NICSHAPE Poshan Yojana, which provides nutritional support and 1,000 rupees to the patient every month in their bank account. Then community engagement, there's Pradhan Mantri TB Mukt Bharat Abhiyan, which tries to remove the stigma of TB. Then Arogya Sati app, which provides counseling to the patient and family members. So the results according to World Health Organization Global Tuberculosis Report of 2024, globally in 2023, 3.2% among new patients had MDR-TB and 16% among previously treated patients had MDR-TB. So India accounted 4 lakh cases of MDR-TB in 2023, which accounted 27% of the global population affected by MDR-TB. So I would conclude by saying that we have to improve our healthcare infrastructure, expand diagnostic facilities, create public awareness, and strengthening our surveillance system. Global intervention is also required. So I would like to conclude by saying that we can end TB, commit, invest, and deliver. Thank you.
It was specifically the department in the department.
No, sir, I just did it myself. Yes, sir. Not exactly, sir. I actually took references from WHO, NTEP, Lancet Respiratory Medicine. I've referred in the references.
About patients, you think about the treatment.
Just treatment.
What about the follow-ups after 4 or 6 months? Patients are waiting for samples here. Anything will solve the treatment.
So usually BPAM regimen is for 6 months, but in case of interruptions for more than 2 weeks, or if the patient has severe toxicity, the linezolid would be tapered off from 600 mg to 300 mg. In that case, it goes from 6 to 9 months.
Patients feel forward to business sampling is everything. Of course, follow what the guidelines say to follow the patients. The categories must be included strongly.
I think clinically we have to ask for symptoms, and then radiological examination, microbiological examination should be done. If it turns out, I don't know.
They say it is going to be probably 90% but you are missing a person and follow the patients and you can't completely say it's 100% your area. Very good presentation. Thanks.
Yes, ma'am. Yes, ma'am. Thank you.
Thank you. Our next presenter is Dr. N.K. Vipisa on the topic non-small cell lung carcinoma. Before that, we'll get into the results of the paper investigation. I kindly request our judges to occupy the stage for announcing the results.
For the facilities that we have. Thank you for joining us. The second prize is to for the second prize is to
பார்த்து படிக்கணும் படிக்கணும் Good afternoon. So I'm going to present a case of non-small cell carcinoma, adenocarcinoma. So introduction: lung cancer are insidious and producing no symptoms until this is well developed. Which is found is the most common symptoms. And in the clinical position, a 65 years old female complains of breathlessness for the past 1 month, and there's a complaints of loss of weight for a woman and loss of appetite for the past 1 month, and there's a history of breathlessness grade 3, which is insidious and is gradually progressive and associated with the wheeze. It's a history of loss of weight in 6 kgs in 1 month and the loss of appetite for the past 1 month. And the patient is a known case of type 2 diabetes and systemic hypertension, and he was on a drug. And there's a history of a biomass exposure for the past 30 years. And the investigations we have done CBC, LFT, RFT, and a serum everything are within the normal limits. And HRCT shows the pressure of left upper lobe tissue parenchymal lesion with multiple nodules in lung as prescribed. And there's a patch area of air space opacities with the ground glass attenuation. We have planned for the bronchoscopy for the patient, and in the bronchoscopy, the left upper lobe bronchial wash was and biopsy was taken and bronchial brush was done. And for AFB and CBNAT, everything turns to be negative. And in bronchial brush, it shows cytology shows that the positive for malignancy. And further, the test was sent patient was sent referred to the higher center for management. And finally, the report shows it's a non-small cell carcinoma. And further IIC shows it is a adenocarcinoma. And patient was started on chemotherapy followed by radiotherapy. Yes, sir.
What is the novelty presenting in this case?
Initially on the case with like a thought pneumonia, like pneumonia மாதிரி question பண்ணிருக்காங்க.
Non-small cell. where you can see the previous video. What is in this space of present suppose. Answers there, that one so critical biopsy. Chemical diagnosis. Okay, what is the one? This patient now chemo radio completed.
So, chemo, during the chemo, first.
Thank you. Thank you, sir. Next, I would like to invite Dr. B.P. Mahesh to present on the topic, a case of pulmonary TB sequence with NPD coincidence.
Good afternoon, everyone. It's a case of PTB sequelae with NTM co-infection. Introductions: a non-tuberculous mycobacterium are widespread microbes commonly found in soil, water, and other environmental sources. Although they can be encountered by anyone, NTM infections most frequently develop in individuals with underlying lung disease, such as bronchiectasis, which leads to permanent scarring and widening of the airways in those with a compromised immune system or in older adults. Objective is to examine and clarify how factors such as bronchiectasis, immunocompromise, and older age contribute to an increased risk of NTM infection, thereby emphasizing the importance of early detection and appropriate management and strategies. A case presentation: a 65-year-old female, a farmer by occupation, came with complaints of breathlessness for 8 years, increased for the past 2 weeks, cough with yellowish expectoration, and low-grade fever for 2 weeks. Patient is a known case of COPD on a normal ICS or on irregular usage. A history of old treated PTB 30 years back, and no history of diabetes mellitus and hypertension. History of biomass fuel exposure present. Respiratory system examination shows a decreased chest expansion of the right hemithorax with bilateral post crepitations, which is more on right hemithorax. Investigations: patient's hemogram, renal, and liver function parameters were normal. Sputum AFP negative, sputum culture, commensals of upper respiratory tract grown, fungal KOH, fungal culture negative, ABP workup negative. Chest X-ray showing bilateral hyperinflated lung fields, right-sided volume loss with bronchiectatic changes in the right mid zone. CT thorax plain fibrobucketic changes noted in the right upper lobe, middle lobe, and irregular segments of left upper lobe. Patchy opacifications with some showing a ground glass attenuation noted in left upper lobe, right lower lobe, and right middle lobe. Tree in bud opacities noted in the right lower lobe. Few tiny calcified granulomas noted in the bilateral upper lobe. Bronchoscopy: both bronchial tree appears normal with thick mucus secretions. Bronchial wash was taken and the bacterial culture was Pseudomonas grown. AFB gene expert fungal KOH fungal culture were negative. Bronchial wash for MGIT was grown. Mycobacterium other than MTB were grown, and repeat bronchoscopy was done for NTM species identification, which showed by Anspure culture showed Mycobacterium cheloni. Diagnosis: non-tuberculous mycobacterial infection with Mycobacterium cheloni. Discussion: NTM species can infect the lungs in patients with structural lung disease such as bronchiectasis, cystic bronchiectasis, or cystic fibrosis or chronic obstructive pulmonary disease. Diagnosis: clinical and radiological both required. Pulmonary symptoms: nodular cavitary opacities on chest radiograph or high resolution computed tomography scan that shows multifocal bronchiectatic with multiple small nodules, and appropriate exclusion of other diagnoses. Microbiological criteria: positive culture results from at least 2 separate sputum samples. If the results are non-diagnostic, consider for repeat sputum AFP smear and culture, or 2 positive or 1 positive culture from at least 1 bronchial wash or lavage, and a transbronchial or other lung biopsy with mycobacterial histopathical features such as granulomatous inflammation or AFP, and positive culture for NTM or biopsy showing mycobacterial histopathologic features showing granulomatous inflammation or AFP positivity, and 1 or more sputum or bronchial wash that are culture positive for NTM. Treatment: antibiotic regimen, rifampicin 600 mg 3 per week, and ethambutol 25 mg per kg, and azithromycin or clarithromycin 2 divided doses in 3 per week. Antibiotic treatment should be continued for minimum of 12 months. Conclusion: the case highlights the rare but important association between Mycobacterium pylori infection and bronchiectasis. The patient's clinical course underscores the challenges in diagnosing and managing atypical mycobacterial infection, particularly in individuals with pre-existing lung conditions such as bronchiectasis. Bronchiectasis predisposes patients to NTM infections by providing a chronically damaged associated with bronchiectasis often leads to a defective immune response, which can result in a delayed or a suboptimal clearance of NTM organisms. Thanks.
So, okay, what will we follow up this way? Meals and from follow to our treatment next. Yeah. How will we treat this patient? Points. DB, what regimen we give. And then follow up it.
என்னோட
பாயிண்ட் மட்டும் பண்ணுங்க. This is the lecture. It was sent by Dr. Prabhakaran sir from Community Medicine Department, Team CH. This picture is from Dr. Tanya Shri from Vinayaga Mission Salem. This one is by Dr. Anu Ananya from Vinayaga Mission Salem. This picture is by Dr. Vishnu Priyaji from Government Tiruvarur Medical College. This is by Dr. Swati M from Indira Gandhi Medical College. This picture is by Dr. Archana Devaganan from Tagore Medical College and Hospital. And this picture is by Dr. S. Kirtivasan from IGMC and RI. So now the results for the competition is the first place is secured by Dr. Vishnu Priya from Government Tiruvarur Medical College and Hospital. And the second place is secured by Dr. Archana Devaganan from Tagore Medical College and Hospital. Congratulations to the winner. This one. Even Tiruvarur Medical College. Vishnu Priya Tiruvarur sir. Sorry. The first place is secured by Dr. Vishnu Priya from IGMC and RI. And the second place is by Dr. Archana Devaganan from Tagore Medical College and Hospital. Congratulations to the winners and all of us.
First prize facing much. First prize online available.
But the photograph, yes. Dr. Vishnu Priya, can you hear us?
Hello, ma'am.
You have been awarded as the first prize for the photography competition. Congratulations. It was rushed by Dr. Niveta. It was done by Dr. Bhavani Niveka ma'am from Harvard Medical College. Ma'am, can you hear us?
Often translated. And he was very informative.
Certificate will be given. 500 cash prize.
The winners will be awarded with the amount of rupees 500 as cash prize and the certificate will be sent.
Runner 2.
And the runners will be awarded with rupees 250 as cash prize. Congratulations.
Experiments. I see. You know. அது யாரும் இல்ல நம்ம அர்ச்சனா ப்ளீஸ் கம் அண்ட் ஷேர் யுவர் வியூஸ் எஸ் இல்லைனாலும் பரவாயில்ல வில் கிவ் சர்டிஃபிகேட்ஸ் கம் ஆமா ஏதாவது சர்டிஃபிகேட் ஏதோ ஃபீல்டு மட்டும் யார் Surely.
I now invite Dr. Pranali ma'am on stage for this presentation. Next, I invite Dr. Vishali ma'am. Next, I invite Dr. Anushka ma'am. Next, I invite Dr. Swati ma'am. Next, I invite Dr. Sandeep Sir to felicite Dr. Kalagaras.
The entire team of community medicine.
I invite Dr. Kalagaras Sir to give the vote of thanks.
இவளெல்லாம் படிக்க முடியும். It's my privilege to give a vote of thanks. This 3 days conference event went on well. It's a successful one. First day we had a workshop at NIRT. Remaining 2 days we had continuous topics and paper presentations. In this juncture, I give my special thanks to our chairperson, ma'am, Dr. Mala ma'am, and Mr. Manikandan sir for their constant support to our departments, and the team, MS, GP for their support and guidance in conducting the program. So there are many supporters for this program from NTP side, the state TB officer and DTO and the TB unit staff are very much coordinated with us for conducting the program in a good manner. Also, we have other department staff, Department of Community Medicine and Respiratory Medicines. We come together and conducted this conference in a successful manner. So I thank each one of you, the entire department and department staff. Everyone put their full effort for the conduction of the program. And I must thank our CMRIs also for conducting this program. Also, I thank NIRT for organizing the workshop in a good manner. It was a lovely workshop. So, and then Vice Principal of Dental College has graciously accepted to provide this hall. I thank other staff, supporting staff, our photographer. So he has constantly with us provided support. All IT, other persons. So if I have missed anyone, a big thanks to everyone. Thank you very much. We'll meet one more time for the one more occasions. And the final thanks to our delegates who have joined physically and virtually. Thanks everyone. Thank you very much.